तो डॉक्टर तिवारी अनम्यूट कर लेंगे, बाकी हम लोग सब म्यूट कर लेंगे उसके बाद जब इनका लेक्चर होगा।
ओके।
Yes, sir, we are live. You can go ahead.
Thank you, Dr. Bijlani. Our first is welcome audience. I welcome all the speakers and the panelists. Today we have 5 speakers: Dr. Satish Tiwari, Dr. Mukul Tiwari, Dr. Patil Jain, Dr. Govind Sethi, and Dr. Rakesh Mittal. We have 3 national speakers and 2 international speakers: Dr. Govind Sethi from UK and Dr. Rakesh Mittal from USA, Florida, USA. Our first speaker will be Dr. Satish Tiwari. He is a consultant pediatrician, professor of pediatrics, and a medical legal consultant. He is stationed at Amravati, Maharashtra. Dr. Satish Tiwari is founder president of IMLEA and founder convener of Human Milk Banking Association. He has been given many orations in the state chapters of Karnataka, Maharashtra, and West Bengal Indian Association of Pediatrics. He is the editor of textbook of medical legal issues. He is founder secretary of medical legal group of I.A.P. He has presented many papers in national and international conferences of pediatrics. And he has been undergraduate and postgraduate examiner in pediatrics. He has many publications in national and international journals. His topic for today is medical legal issues of neonatology. Welcome, Dr. Tiwari. Over to you.
Thank you, Dr. Sirohi, and thanks the IMA Uttarakhand as well as IMLEA, and special thanks to Dr. Sirohi as well as Dr. Anurag Verma for giving the opportunity to speak in front of this august gathering under this national and international webinar. So I thank everybody, and we'll discuss a very important issue, that is medical legal issues in neonatology. And I request Dr. Sirohi to give a indication after 15 minutes when I have to stop. Okay. So we'll discuss the legal issues in neonatology. The practice of medicine in last few decades has evolved from arts to science. Then, of course, it became the commercialization, and unfortunately, we did not stop there. So now we have to learn the legal aspect of medical practice. Similarly, the last few decades of medical practice has seen many positive changes as well as some negative changes. And because of these changes in the medical practice, there have been various changes in the problems associated with medical practice. For patients, now there are many government schemes, including the Ayushman Bharat. There are many insurance schemes. And because of this, as the patient is paying as per the charges of the hospital, he has a soaring expectation, and there is a increased degree of accountability on the hospitals and the doctors. But finally, we have to remember that in medical practice, the Hani Labh, Jeevan Maran, Jas Apjas is Vidhihat. So, those who cannot understand in Hindi, the loss and gain, life and death, fame and defame is in the hands of luck and destiny. A very important question: who is a specialist? According to Park's textbook of PSM, a person who learns more and more about less and less is expert in that field. According to Medical Council of India, a person who has a special qualification in that branch is a specialist. So if we are talking of neonatology, there has to be a specific degree where the neonatology has been taught to the UG or PG student. According to Supreme Court of India, we have to work within the scope of our qualification and the skills. If we do not follow this, then we are not a specialist, rather we are a quack. So as far as neonatology is concerned, you can have a degree of diploma in child health, M.D. Pediatrics, DNB in pediatric, or DM in neonatology. Then of course, very important two words which should be understood clearly as far as the legalists are concerned: consultant neonatologist versus expert neonatologist. My personal opinion is we should write consultant neonatologist rather than writing the expert in neonatology. Then of course we are coming in the era of super specialty, and similarly then there will be cross specialty and cross pathy. According to most of the judiciary people, attending seminar or CME may not make you the specialist. You require a specific qualification. And if you are a specialist, please try to avoid doing the general practice. As far as neonatology is concerned, the setup, we have to look at the facilities, space, the instruments available as per the scope of practice. The staff should be trained, and of course, in our absence, there should be proper delegation of duties to the attending staff. As far as instrument and facilities are concerned, non-availability of instrument, can it be taken as a negligence or deficiency in service? There is a lot of discussion about this, and that's why we should have the instruments and facilities as per our field or the scope. So depending upon how much specialization or super specialization we claim, we should have the facilities and the setup. Do not promise what is not available. So for any reason, if the ventilator is not available, we should inform the patient in the beginning itself that ventilator facilities are not available at our place, and if the child requires ventilation, you may have to go to some other place. For any procedure or for most of the procedures and treatment, a consent is important. So for mechanical ventilation also, a consent is required. In fact, the consent should be informed consent, except sometimes in emergency or for the life-saving measures. Can the instrument be shifted to a patient with better prognosis? Again, this is a very important question which needs a lot of discussion. That means if we have two newborns and we have only one ventilator, suppose it's already on one newborn and the second newborn comes with the better prognosis, should we shift that ventilator to the second patient or we should continue with the first patient? There is a lot of discussion about this, and there are various situations when this may be required. This is one of the important case, a decision of 2008, where a child with fever for 20 days, X-ray and echo reports were not correlated. The child was grossly hypoxic, ABG was not done, not put on ventilator, he was discharged forcibly and died on the way. It was proved in the court of law that records were fabricated and not reliable, and lame excuse regarding why the ventilator from their own hospital was not spared. So in this case, negligence was held. As we discussed about delegation of duties, the duty has to be delegated to a qualified, competent junior assistant or nursing staff or a lab assistant, depending upon the duty or the work which is to be done. The responsibility switches over to the delegated person if he is qualified, and if the person is unqualified, there is vicarious liability on the expert or the doctor or the hospital who is managing the patient. So that is very important concept of vicarious liability. As in other patient, we should take history and examination in detail, especially the history of allergy is very important, history of related illnesses, and especially in newborn, ask the predisposing factors during pregnancy which can be the cause of the illness or the problem in the neonatology. You can see a photograph at the right hand corner, and this is, have you ever filed a case against doctor in practice, in past? So this is a new history. Now we are recommending to our colleagues that you can have some idea about the problem to be created by patient in future. So though this is not required scientifically, but in order to protect ourselves, we can ask this history. For any reason, if we are examined in a hurry, asked to come for review on the next day, and document it on the paper that diagnosis is under review if not confirmed at the first examination. Investigation is equally important. Avoid necessary investigations. At the same time, do not advise unnecessary investigation. It's very important in newborn. If there is a birth asphyxia, if you do not advise CT or MRI, many times there can be problem that we do not know what was the scope of, what was the extent of brain damage. At the same time, if you advise investigation, somebody may have the allegation that why you have advised MRI in such a small child. So you have to weigh the advantages and disadvantages. If the relatives do not do the suggested investigation, it contributes to contributory negligence. Very important in the present era, the screening for recommended disorders in newborn is very important, especially the screening for metabolic disorders if we suspect, or for the simple hypothyroidism or cretinism. Though this is a old case, 2004 National Commission judgment, but most of the principles, they are applicable in the present circumstances also. Here the case was of a prenatal test which was negative for thalassemia. So first baby was thalassemic. And second time when the mother was pregnant, she was screened for the intrauterine baby for the thalassemia, which turned out to be negative during the antenatal period. But subsequently when the baby was born, he was thalassemic. So the National Commission in this case says that the process of prenatal diagnosis is complex. Genetic technologies have not developed to the extent and may not be free from all the errors. No scientific technology can be 100% perfect. The error is inherent in nature and multifactorial, and there is a very thin difference between error, imperfection, and negligence. So this thin line or thin difference between error, imperfection, and negligence persists in this era of technical advances also. But only thing is we have to be very careful while suggesting the investigation. As far as treatment is concerned, again, in pediatric practice, we have about the wrong medicine, the overdose, and some age-specific drugs. Tetracycline is not used nowadays, but we have the quinolone derivatives. There are many other drugs which may not be indicated in children, especially in neonates. So we have to keep all these in mind. And of course, second opinion, as I said, if you are not a neonatologist, you can have an opinion of neonatologist. Of course, the Boehm's principle we'll discuss subsequently, and we have to avoid cross-pathy. This is one of the case in neonatology where a newborn child was, to prevent hypothermia, he was given hot water bags post-operatively. There were burns on both the legs and subsequent deformity, and this was taken as a negligence. This very important 11 crore case, judgment in 2009, where they have discussed about the Boehm's principle and cleavage of the opinion, and where the Supreme Court has nicely analyzed that there can be pro-steroid group and anti-steroid group, and you have to weigh the liability, you have to weigh the chances of treatment, the chances of complications, and though there can be cleavage of opinion, but if you follow any one group of the academicians, you may not be at fault. During this case only, Supreme Court says that the negligence cases are increasing in United States. This is of 2009, so almost 10 years back. Doctors as well as health services are insured. Insurance companies are increasing the premium, and that's why the health services are becoming costly. Similar situation may not be proper in India. Doctors may refuse to treat, and younger generation may avoid medical courses. Unfortunately, in spite of warning from the Supreme Court that this situation may be a disservice to the community and must be prevented, we are making the mistake of increasing the insurance, increasing the cases against the doctor under the CPA, increasing the limit of compensation. There is no capping on the compensation, and all this is creating problems in the present day medical services in India. But this was expected by Supreme Court in 2009. A very interesting case, 2015 judgment, where a full-term 3.1 kg baby who developed jaundice on the 4th day of the life, baby was shifted to NICU without the mother, and he was fed on the powder milk with bottle. This baby vomited, there was aspiration pneumonia, septicemia, multi-organ failure, and died. Now in such cases, it is difficult why the baby was shifted on the 4th day for a full-term baby, whether it was a pathological jaundice or not. The baby was shifted, why the mother was not shifted and the breastfeeding was not continued. And even if the top milk was given, why it was given with bottle. So all these things are there. It's really very difficult for us to defend these cases. And in this case also the compensation was awarded. This is a model of ideal prescription suggested by MCI. We do not know now with the dissolution of MCI how much will this be followed, but it is otherwise also a recommendation and not a law. And according to this, the prescription should have all these details which you can see on the screen. The treatment should be written in preferably, if possible, in generic names and in capital letter. And the size of prescription is also prescribed, that is 14 by 21 centimeters or 11 by 11 centimeters. As far as withdrawal of life support and DNR guidelines are concerned, though they are very important, at present the Indian law is silent or ambiguous on this. Last year in 2019, we have a ICMR meet on this do not resuscitate guidelines, and it has come now in the journals of the ICMR, but still most of the situation is ambiguous and still not clear as far as DNR is concerned, especially not only in the adult but also in the neonatology. Who should decide about the do not resuscitate action guidelines also are not there, and overall still this subject remains a complex subject. As far as the complications are concerned in neonatology or in other practice, many times they may be self-limiting, like even birth asphyxia to some extent. If it is mild, it is self-limiting, no problem, but it can be progressive and damage can occur. The progression can be mild or fulminant course. So what is important as a qualified person, we should have the foreseeability of complication. And if we feel any complications are there, there should be proper diagnosis, proper treatment, as we discussed that the facilities should be there. And if the facilities are not there, a proper referral at proper time is very important. So complications that are too remote will not be taken as a negligence. The two important cases related to retinopathy of prematurity. This is a Supreme Court judgment against the state of Tamil Nadu. So government medical college or government hospital, where Supreme Court says the very important yellow color lines, the baby was isolated and confined to the four walls of sterile room to prevent the infection. But as far as ROP is concerned, that is retinopathy of prematurity, it was neither screened nor advised. So it is very important for us to screen for the ROP and advise proper screening even after the discharge. So because of this, deficiency and negligence was held and 1.8 crore were sanctioned against the state of Tamil Nadu and that hospital, which is the second highest sanction at present as far as the India is concerned. So after that 11 crore, this is the second highest compensation. In this case also, retinopathy of prematurity, 64 lakhs were awarded, where no test for ROP was done in 4 to 5 weeks. And there was no clear documentation that test was advised before or after the delivery or discharge. So it is very important to advise the screening for the baby. Referral, as we discussed, if the case is beyond one's qualification, skill, and experience, we should not exceed our level of competence. It's always better to refer the case after giving the life-saving measures and at the same time hand over a proper referral letter to the patient or the relatives. As far as consent is concerned, it should be a proper consent, a proper documentation of the consent, and you can see the underlined line. In case of critical baby or neonate, almost daily consent should be taken that what is the status of the child. So you have to inform at least once to the relatives that baby is still critical and we cannot comment about the outcome of the baby. So this is informed consent where you have to give information in comprehensible, non-medical terms, preferably in local language, about the diagnosis, the nature of treatment, the risk involved, prospect of success. So all this should be included. And even the expenses or bills or the charges or the cost of the treatment roughly should be informed. Recently, there was one National Commission judgment where it is said that pre-printed consent form may not be proper, but we still feel that if you keep sufficient space for writing the specific case related to that particular case, you can have some basic pre-printed consent form, and in between the space you can write the specific indications or specific treatment suggestions in that pre-consent form. Negative consent is equally important. Documents, please remember, are the property of the hospitals, but they have to be given to the relatives, maybe on return request within 72 hours. This is as per MCI guidelines. And do not try to manipulate with the documents. This is, though a old judgment, again very important judgment, 2007 judgment, National Commission. It is important and incumbent upon doctors to maintain the record. The discharge summary must have the various detail, and it shall not be mechanical but patient friendly. So what is patient friendly discharge summary for, especially for a neonate? We must advise exclusive breastfeed, advise immunization as per the age, ocular examination, especially for the ROP and other problems. Auditory examination is very important. We have one case from Maharashtra where the problem with hearing of the child was diagnosed somewhere around 1 year, and then the case was there that why you missed that up to 1 year of age. Assessment of growth and development. There is a case in National Commission for 3 crore for why the proper assessment of growth and development was not done. Any other advice related to that particular case, and at the same time we have to advise follow-up which after the discharge can be every day for few days or few weeks, then it can be weekly or monthly. So you have to write everything in clear-cut words, and that is a patient-friendly discharge card. Some of the times, especially you have to inform the police, especially if there is some unexpected death or some unexpected diagnosis or undiagnosed death. So this is a list where police must be informed. We personally feel most of the medical legal consultant that it's always better to inform the police rather than patient going to the police. These are the aggravating factors. The most important is the criticism by our own colleague, what is known as medical jousting. So that we have to keep in mind. We have to be aware of the so-called social workers, ambulance chaser advocates, and of course the complications and death of the patient. If you look at this chart, this is a analysis of National Commission judgment. Again, a old analysis, but very important. This is analysis of 155 cases between 1992 to 2007. You can see the pediatrician are at the bottom in this list, but now the things are changing. And why pediatricians are at the bottom is one of the reason is that most of the times we give guarded prognosis. Like a newborn, if he is 1 kg or 32 weeks, very severe premature, then we tell in the beginning only that this patient is not going to survive, or if he survives, there can be a lot of disabilities and morbidity. So that's why please give guarded prognosis. Unfortunately, if there is a case in the court of law, we should not get frightened. Stay calm and avoid anger. Take the help of legal as well as medical legal consultant. Ask for expert witness, and of course, at the same time, we should not be overconfident. As we have discussed till now, should we consider all patients as future and potent litigants? Again, our suggestion is yes, every patient should be considered as a future or potent litigant. And that does not mean that we avoid each and every patient, that he can go and sue us or have the allegation of negligence in future. So we don't suggest to stop our practice or stop seeing the patient. What is important, we should have a proper document so that if a patient goes to the court of law, we can defend the case. About insurance, it is really important to have insurance, professional insurance. And if we can have insurance for our car, for our instruments, for building, why we should not have the professional indemnity? The thing which is important is which indemnity we should take from national companies, from medical legal association, from IMA, or from various so-called service provider companies. So we have to decide which will be helpful to us in future, and then we should have insurance. So the reliability of the company, the last line in this slide, is really important. Of course, we have to read in between the line whichever policy we take, and we have to be very careful. How much amount should be taken will depend on many things. It depends on the type of practice you have, the place of practice you have, the specialization or super specialization. And this is one of the scheme run by Indian Medical Legal and Ethics Association for their members. This is done in collaboration with the insurance company, that is New India Assurance Company, and the charges are almost 1/3 to 1/4. So around 30% charges are there as compared to if you directly go to the company. As far as the preventive aspects in the present era is concerned, how to prevent the medical legal negligence or allegation of deficiency in service, communication is very important. I think Dr. Mukul Tiwari sir will discuss in detail in the doctor-patient relationship. We should explain the misunderstanding and misrepresentation, explain the treatment modalities, especially in the complicated cases in simple language. Queries must always be solved, and we have to behave in compassionate, sensitive, and humanly manner. Do not avoid communicating with the relatives. Many times our colleagues ask, Dr. Saab, there is a lot of problem. So, two relatives come and then we explain everything to them. After half an hour, another 4 or 5 relatives come and we explain again everything. Next day, 8 or 10 relatives come and again we have to explain everything. So what we can do, we can ask the patient or the relatives that those relatives who are present, everybody should come and we should explain the things with the available relatives. Not only this, the various academic universities, including the whole of the universities from the India, now they have included communication skill, professionalism, and medical ethics. And in 2019, the Medical Council of India have also included all these medical legal issues in the UG as well as PG curriculum. The another best option or one of the best option is group practice. There are a lot of advantages of group practice. It may not be possible to cover in this 15 or 20 minutes talk, but always explore the possibility of group practice. It is very much helpful. It decreases the stress and strain. Our knowledge can be updated regularly and different subspecialties can be under one roof. Very important is crisis management committee. If there is any crisis in any hospital, we should have a crisis management committee consisting of doctors, social workers, politicians, legal personalities, press reporters, etc., who can reach to the spot of controversy and they can have some trial for the settlement between the involved parties. Now the mediation cell is included even in the Consumer Protection Act. I think the crisis management committee can be one of the prerequisite or one of the pre-option before going to mediation cell. Or we can have this committee who can give recommendation to the mediation cell and the mediation cell can act on the recommendations from this committee. Of course, as we discussed, we have the Indian Medical Legal and Ethics Association, and this webinar we are taking in collaboration with IMLEA and the IMA Uttarakhand. Almost because of the Herculean efforts by Dr. Anurag Verma, there are around 30 members from the Kashipur. I would request all those who are listening to today's webinar to become the members of this Medical Legal and Ethics Association. We have a separate advocates wing also where we'll be having the advocate members. We have for all different subspecialties and for different specialties, including dental, homeopathy, Ayurvedic, and we have even membership for the hospital management teams or the management in charge. So we have a separate for the hospital managers. This is the quarterly journal which we have under this Indian Medical Legal and Ethics Association. Role of governments we have discussed many times, especially in preventing the incidences of growing physical assault. Now almost more than 25 states in India, they have the Medical Protection Act or Medicare Protection Act, and the hospital and the nursing staff, everybody, the health workers are protected under this. And according to this act, imprisonment for 3 years plus minus fine of 50,000, penalty twice the amount of property or instrument damaged, and this offense is cognizable and non-bailable. What is important? We should take the help of this act. This is the from Maharashtra police that this act is there and you should take the help of this act if there is some violence. So finally, what to do? We have to do a lot of soul searching. The profession and commerce need to be separated. We have to think whether it is the 5-star healthcare facilities which is required, or do we require healthcare facilities for the masses rather than the classes. Human touch and ethics are very important. And for all this, is there political willingness, or there is apathy and anarchy amongst the politicians and the government? So finally, before I conclude, we should do right things and have the clear conscience. We must follow the morality and rules of the medical practice. Should have a good rapport with the patient and others. Instrument knowledge should be updated with the research development. Quality of medical graduate is very important. Now NMC is also planning for the changes in the setup of the medical colleges and the hospital beds and all this. So I think it is important that the quality of medical graduates is very important. We already discussed there is a need for insurance which will give the our financial protection, and of course the IMA, IP, medical legal cells of various organizations. We have surgical organization with medical legal cell. We have, as we discussed, a whole association which is looking after the medical legal and ethical issues. So what we should do, we should be a continuing medical educated doctor and not a company medical representative educated doctor. Please avoid cross-pathy or cross-speciality. And of course, before I stop, again let me thank the IMA Uttarakhand and the IMLEA. And before I finish it off, whom do we want to worship? It's a very important question. Do we want to worship Lakshmi, that is only money? Do we want to worship Saraswati, that is only academics? Or we want to create a Tandav Nritya in the medical practice, the Nritya which was done by Shivji, or we want to do the social service as was done by the Mahatma Gandhi. After this lecture, I think, as we discussed during the lecture also, many of our colleagues said, Dr. Tiwari, we are so much frightened that we feel now we should stop the medical practice. So tell us the alternative, what we can do from today. So alternative business or alternative things which we can do. I think there is no need to get horrified. We should have the practice which is ethical, which is there has to be something midway between the commerce and the academics. And thank you again. Thank you, Dr. Sirohi and Dr. Anurag for this special opportunity. Thanks.
Thank you, Dr. Satish Tiwari. Our next speaker is he is also a pediatrician, M.D. D.Ch, Fellow of Indian Association of Pediatrics. He is a consultant pediatrician and is also the State President of IMA Madhya Pradesh, based at Gwalior, Madhya Pradesh. He has been having many responsibilities on his shoulders. He is the editor of textbook of medical. He has been National Chairperson, IMA Standing Committee of Child Health, Member Bioethics and Medical Legal Committee, Member Legal Assistance Scheme, IAP, Central Council Member, IMA, and many other things to his credit. He is the receptionist of Dr. B.C. Rai Ocean Award, author best-selling book A to Z Baby Care, member Managing Committee Roshni. He is editor of textbook of medical legal issues. His topic for today is doctor-patient relationship. Dr. Mukul Tiwari, please.
Good evening to all, and thanks, Dr. Sirohi. I am going to speak about doctor-patient relationship. After the impressive talk of Dr. Satish Tiwari, I am somewhat at a disadvantage, but I'll try to do justice. So, why we need to talk on this topic is very important. Is it so important that we should give 20 minutes of our time to think of this? Yes, because there is an increasing tendency to put blame on the doctors. Politicians and media, they are giving populist statements. They are with the public, not with you. There's a fearful working atmosphere. Many doctors who are competent, they are not able to work because they are afraid. So a patient gets transferred. A patient who could be treated in district gets transferred to a bigger town, from there to a metro, a corporate hospital. So their expenses increase many-fold. So now what to do? What should we do? Put entire blame on the society and the patients, they are villains, or we can do some introspection and try to find solutions. I think we should try to find solutions instead of talking negative all the time. This is the first treatise in the doctor-patient relationship, Hippocratic Oath. This is the classical oath which is not acceptable to doctors of modern times because it has many clauses which are not relevant in today's regard. You can see this. This is anti-abortion. Then the problem of disclosure. I will not use the knife. This is against the surgeons. So classical version is gone out of fashion. Now there's a modern version. And when I read it, I found that it is very nice. It is a very nice treatise. And if you read it carefully, afterwards you can take out on the internet the modern Hippocratic Oath. And if you read it, you will realize that's really very good. If we follow this oath properly, then we'll have negligible problems. So please try to read it after my talk, after this session. Because time is less, so I don't have time to read it out, all of it. There's one IMA oath also. There's one Geneva oath also, which came during the Second World War. So different kinds of oaths, but most relevant is Hippocratic Oath. And I don't know how many colleges they are subjecting their new students to the Hippocratic Oath. And there's also some confusion. Some are subjecting to the old oath and some are subjecting to the new oath. Anyway, so what is fiduciary relationship? Fiduciary is a Latin word for trust. The bond of trust between the patient and the doctor is vital to the diagnosis and therapeutic process. So this is the most basic tenet of doctor-patient relationship, trust or confidence. Now, how the relationship changed in the last century? Before the 1950s, there was a paternalistic model, which meant that the doctor was father and patient was child. The child has to follow all the directions of the father, all the dictates of the father. And he was a sort of slave to the father. But during the second half of the 20th century, the doctor-patient relationship evolved towards shared decision-making. This model respects the patient as an autonomous agent with a right to hold views, to make choices, and to take actions based on personal values and beliefs. And we should not feel bad. Those who are 50 years or more, We are used to taking the patients for granted, and we feel bad when the patients do not agree to our decisions. We think they are rebels and they are bad patients, but we should respect their choices, the choices they want to take up. Patients have been increasingly entitled to weigh the benefits and risk of treatments, including the alternative of no treatment. The patient may go back from your clinic, from your hospital, and we should not feel bad. They have the right. Now, what is doctor-patient relationship is basically a tug of war. To the doctor, illness is a disease which can be measured and understood through lab test and clinical observation. To the patient, illness is a disrupted life. Doctors' focus is on keeping up with the rapid advances in medical science. But patients' satisfaction comes primarily from a sense of being heard and understood. Many doctors do not see the role of physician as listener. They don't want to listen, but instead view their function more as a car mechanic. Find it and fix it. Now, the factors behind deteriorating relationship. There are intricate social dynamics. There's a general loss of respect for authority. There is even hatred for authority figures. There's a trend towards patient autonomy. There is increasing social anger. We can see the mob behavior everywhere, violent and turbulent, society, easy provocation, jealousy with doctors' prosperity. The knowledge that doctors are softer targets. They can be easily attacked. Then practice dynamics, the CPA came and evidence-based medicine came more into the trend. There was increased expectation from the patients about early cure, and there was fear of losing the patient by the doctor. So it led to increased specializations, hospitalizations, overtreatment, costlier medicine, which led to further worsening in relations. Now, many doctors, rather most doctors, they have poor rapport and communication skills. That is also a big factor. Then increase specialization. Specialists and super specialists, they can't give much time and personal touch to the patients. Old practice of family doctor was good and it should be revived. And a family doctor is not our enemy. A family doctor can be a buffer between the patients and the specialist. We can make him our friend. Commercialization. Now it's a big problem. Medical profession began as an art, then it became a science, then now it's a business. But doctor is not to blame. All around there is a money culture. So what is doctor to do? He has to pay a fee for his children. He has to maintain a car. He has to buy things for his wife. He has to pay the house rent, etc. But still, despite all the adversity, we have to remember that once we have chosen this noble profession, then we should try to avoid temptations of material gains and try to stick to morality and dignity of our profession. So it's all about thinking. We can be like how the priest behave without the temptation. Then the role of media, it's very important. The media is mainly responsible for all the disturbances which are happening in the hospitals with exaggerated reports about mob violence, which encourages others to follow example. Carelessness of the doctor, they give news like that. Doctor ki laparwahi. Then lawsuits against doctors. This all encourages others to follow example. They think it's a done thing to do vandalism in the hospital if there is any death or the patient worsens. Then there's abundance of doctors. That is also one factor. There are too many doctors, so there's little respect for your value. Lack of unity. There should be a system of giving feedback to each other for miscreants. In every city, this system should exist. In my city, this system is there. We are giving feedback to each other that this patient created problem in our hospital. So please take care if he comes to you. Backbiting, we are often giving negative feedback about our colleagues to patients. It results in more lawsuits and decline in the feeling of respect for doctors in general. Then unethical and greedy attitude tarnishes the reputation of entire community and nurtures distrust against doctors in general. They all know these days that there is a commission system. So there should be something about this. Either it should be made legal or it should be stopped. And in surgicals also, there should be limit what we can charge. Sometimes the print is 5 times or more from the actual cost, the surgicals we use in the hospitals. So about that also we should think. Then internet savvy patients, they are increasing. They come with a lot of knowledge of the illnesses and they have high expectations from us that we should know everything about the condition. And see what the internet is teaching to the patients. There are many wicked websites which are teaching, giving wrong ideas to the patients. I saw somewhere this 3 golden rules. Ask lots of questions. Don't worry whether your doctor likes you. Remember that this is a business transaction. Now, how to improve the relationship? Let's come to the solution. Forget doctor-centered relationship or doctor-dependent relationship. As I said early in the talk, that you are no more the father and the patient your child. Now the new mantra is doctor-patient partnership. In this concept, doctor and patient, they become partners through shared decision making to achieve maximum benefit for the patient and peace and happiness for the doctor. This is the old approach. And sometimes this is the new approach. Sometimes patient-controlled consultation. But both are wrong. This is the balanced approach. Then the length of consultation give average 8 minutes. At least 8 minutes, if not more. And better will be 15 minutes to each patient. Some doctors are very proud that they are seeing 200 patients a day. And one doctor told me that I'm giving only 1 minute to one patient. So this is not a thing to be proud about. Give more time, see less patients, but be more attentive. And enjoy your life. Your children are waiting in the hotel. It is your son's birthday. The whole family is waiting that Papa will come and Papa is busy in seeing 200 patients. So take out time and enjoy your life. All these patients will forget you as soon as you are dead. Then maintain transparency and honesty. Patients always appreciate these qualities and they are good buffers against hostile behavior. As I said, communication skills, and it will take a whole session to teach you about the communication skills properly. So you can see afterwards how to improve your skills. These are some tips, but you can see afterwards. Medical interview. What should be the constituents? Establishing rapport, a greeting when the patient comes, discovering the reason for visit, then examining the patient, discussing the condition, establishing a treatment plan, and terminating the exchange. All these steps should be there if you want that the patient should go back satisfied. How can we improve our listening skills? So these are some tips again, which you can see afterwards. We don't have much time. Eliminate distractions, concentrate, focus, maintain an open mind, look for non-verbal clues. What the patient is thinking, what the patient is wanting to say, which you're not catching, then he will not come back again. Do not react to emotive words, ask questions, etc., etc. Increased time with the patients results in better care, saves money spent on unnecessary interventions, and prevents avoidable misdiagnosis, mistreatments, and patient misunderstandings. Now, these are some do's and don'ts with the angry patients. If the patient is angry, listen with concern, appear calm, maintain eye contact, don't run away. Allow time to ventilate their feelings. Don't stop them. Let them say what they want to say. Give appropriate reassurance. Be genuine and conciliatory. Search for hidden agenda. And these are the don'ts. Don't touch the patient. Don't meet anger with anger. Don't reject. Don't be judgmental. Don't go overboard. Don't be a coward. Don't run away, and don't talk too much. Humor and friendship in workplace is very important. A joke a day will see that you never get a case against you. Patch Adams, I hope everybody has seen this movie. Then know your limits. Never attempt efforts to treat a case which is beyond your level of expertise. Always ask for a second opinion or refer. Keep qualified staff. Staff behavior is very important. You're not there all the time. Sometimes they misbehave. They don't know how to behave properly with the patient and the attendants, and it causes bad will against you. So they should be very humble and trained not to give unqualified answers and comments. Then keep the patients informed at every stage about the condition, prognosis, and expenditure. Develop empathy. Empathy is a special emotion. Don't show sympathy to the patient. He doesn't like it. Show empathy. Empathy is you should start feeling what the patient feels. Go over to his side. Improve your services and match with the fee structures. You're taking too much fees, so you're charging very high, and your establishment is shabby, your reception is shabby, then it will go against you. Avoid unnecessary admissions and investigations. Show genuine concern. This is empathy. Already we have talked about this. Then take up a holistic approach. Don't treat only the body. Treat mind, body, and soul, all three together. Now, this is a scoring system to see how much liable you are to get sued by the patients. In this score, in this table, if your score is above 50, then you are in good condition. If it is below 50, then you are liable to be sued. There are total 19 points. And if you get higher marks, you are in a better position. You can take this chart later on from me. Now, frustrating patients, definitely, despite all your efforts, there will be some patients who are frustrating. And difficult patients. Now, a study was done in Singapore. What makes a good doctor? An opinion was views of non-medical professionals, and you will be surprised to see that in their preferences, what they said. philosophy and holistic approach, attitude, human touch, sincerity, compassion, competence, courtesy, and knowledge. So you will see that what the patients prefer. The competence is coming on number 6, and knowledge is coming number 8. But your attitude, your human touch, they are coming higher in the preferences. So thank you so much for patient listening.
Thank you, Dr. Mukul. You told very, very good things and in very short time, really beautiful.
Thank you, sir. Thank you so much.
Our next speaker is Dr. Rupali Patil Jain. She is an ENT surgeon and a medical legal consultant. She is based at Amravati, Maharashtra. She has also done LL.B, P.G.D.M.L.S, P.G.D.H.H.M. She is Secretary IMLEA, Amravati branch. She has given many lectures in several medical, legal and specialty conferences and helped many doctors by drafting their medical legal cases. She is the owner of great voice and a very pleasant personality with a winning smile. Our topic for today is do's and don'ts to avoid litigation. Over to you, Dr. Rupali. Please unmute yourself.
So hello everyone. At the outset, I would like to thank IMA Uttarakhand and the governing body members of IMLEA for giving me this opportunity today here. So Dr. Sirohi has already given my introduction. I'm Dr. Rupali Patil Jain. I'm an ENT surgeon with special interest in allergy. I'm also a medicolegal consultant with a Mumbai-based legal firm, J & Company. So today I'm going to talk on do's and don'ts to avoid litigation in medical. Should not happen. We should not commit any kind of mistake so that the patient will file a case against us and he will drag us to the court. So always there's hello. Hello. Am I audible, sir?
Yes, you are audible.
I had my connection got disrupted, I think.
Start it again.
Yeah.
It is there now.
So today I'm going to talk on do's and don'ts to avoid litigation in medical practice. We all know that we always have some tension in our clinic whenever a patient comes to us so that he doesn't drag us in the court. So I have prepared some few points which I'm going to tell today. Many points Dr. Satish Tiwari sir has already covered. One thing I would like to tell that I am today equally anxious as well as nervous in front of Dr. Satish Tiwari because he is my teacher. He has taught me during our UG days, and even the medical legal knowledge what I have gained is all from him. So these are some of the areas where we land in trouble. When I meet many doctors, I see that almost 90% of the doctors, they don't know how actually an informed consent should be, how it according to the Supreme Court guidelines, and they commit. Many doctors, they even take a blanket consent. So an informed consent lands us in trouble. Then we doctors are very lazy. We can call us lazy in maintaining proper documents. So proper documents, because only the documents they speak in the court. The cases they run for years. And in such cases, even we don't remember some cases. So in such cases, documents are very essential and only they speak in the court. Medical errors, which are usually committed by nursing staff, and we can be held vicariously liable. Surgical errors, which can be due to the surgeon, anesthetist, or the nursing staff. Sometime when a death is there in the hospital, suddenly we get panic. We panic, and then we might commit some mistakes. So how we should be able to handle death in the hospital? If a complaint is filed against us in the court, we don't reply to it, or a reply is not proper. So giving a proper reply to the complaints which are filed in the court against us. Good communication skills, Dr. Mukul Tiwari sir has already talked about it. Practicing in unethical ways and not knowing the duties of a doctor. Many of the doctors, we don't know what our duties are and what the common laws are. And so it is very necessary to attend such kind of medical legal webinars. It is said that we learn from our own mistakes, but in our practice, we should learn from others' mistakes, because once a case is filed against us, there is no chance. We have to go to the court and we suffer from emotional, mental, physical, and financial trauma. And it goes on for years. Now, what are the do's to avoid litigation? I won't talk on this point. A good relationship, it always starts with how it's the basic foundation of a relationship between the doctor and the patient. A good communication is very, very important. Then coming to, we have to know what current practices are there in our practice. Whatever new treatments are there, we should be well conversed with it. We should know, we should attend all kinds of conferences. Then the infrastructure of the hospital, the paramedical staff, the other staff, the hygiene and the sterility, it should be observed strictly. This has been given in the case Martin F. D'Souza versus Mohammed Ishfaq. Then in this case, M. Ramesh Reddy versus State of AP. There was this patient who fell on a wet floor in the hospital. He had head injury and therefore he died. And so a case was filed against the hospital. So use of hand railings, wet floor sign, bed with railings, lifts, emergency bells, all are very important, or they can land us in a civil court. Then many patients, they file case against us because of nosocomial infections in the hospital. So a microbial surveillance of the operation theater and ward should be carried out on a regular basis. Duties should be delegated to the trained staff. It has come under the vicarious liability. Now coming to the informed consent. Informed consent, many doctors, they don't take even for minor procedures, but the Supreme Court has said that any procedure, even if you're intervening the patient's body, you have to take a consent. So even for minor procedures, like in ENT surgery, even for wax removal or a foreign body removal, we can damage the tympanic membrane. So it's better to take a consent form, informed consent. Try to take the consent in the patient's own language. There should be a separate consent for admission, for surgery, anesthesia. Many doctors, they take a single consent for surgery and anesthesia, but you have to take a separate consent for surgery as well as anesthesia, HIV testing, blood transfusion, and a negative consent. Like if the patient is not agreeing for the treatment, you have to take a consent for refusal. Now there's a recent judgment that the consent should be procedure specific. Dr. Satish Tiwari has already told about it. Adequate information. What adequate information should be given in the consent form. First is the nature and the procedure of the treatment. In a brief 4 or 5 lines, you have to mention what type of incision you are doing, what route, either it's an open abdominal approach or a laparoscopic approach, whether hysterectomy is done by the vaginal approach or the abdominal approach. It has to be mentioned what all organs you are going to remove in brief, in the language the patient understands. You have to mention the purpose of the treatment, that is why is the patient getting treated, what is the diagnosis of the patient, how will he benefit from the treatment, whether he will be able to walk properly, whether his pain will reduce, whether her bleeding will reduce. All these things, they have to be mentioned. outline of the substantial risks, and a very important point which everyone misses, what is the alternative to the proposed treatment? It has to be mentioned in the consent form. Then sixth point is adverse consequences of refusing treatment. If the patient refuses treatment, what consequences he might face, it has to be mentioned in the consent form. The consent form, it has to be signed by the patient, 2 witnesses, an operating doctor and anesthetist. Here I would like to tell one point that many times I have seen that when the patient, usually the doctors, they take the patient's signature on a consent form just before the surgery. You should give adequate time to the patient to decide whether he really wants to undergo that surgery or not. And many patients on the time they refuse, or either they say in the court that we did not get time to even think about it. So I believe in the concept of implied consent. So when the patient, I don't know, in India, some hospitals are giving, but in other countries, they are giving an information leaflet regarding the disease. So when the patient comes to you, give him a leaflet, what all procedure he's going to undergo, he might have to undergo, what are the risks, what are the alternative treatments. If we tell him beforehand, he will have ample time to decide whether he really wants to do that treatment, and he will make up his mind and come. So the chances of litigation will definitely reduce. Now coming to the medical records, these are all the types of medical records which every hospital or a doctor should have. The prescription letter, many of us doctors, we write on the prescription letter that this is not intended for medical legal purpose, but any paper, when there is a duty has been established between the doctor and the patient, any prescription you are giving to the patient, it is a medical legal record. So coming to the prescription letter, when we were doing our PG days, we used to write the patient's complaints, the clinical examination findings, the investigations advised. But once we come in actual practice, we just write the diagnosis. We write the investigations on the referral letter, and we give it and the treatment. So if we write all these points on the prescription letter, definitely when in future, if the patient goes in court, we can definitely defend. We can have a good defense in the court. And do not give prescription without actual examination of the patient. All the documents, they should be legibly written. They should be clearly understandable. Sometimes even the judges don't understand and they can give a decision against you. All notes, they should be with date and time, signature, and with the name and the designation. This is a very interesting case, Manmohan Kaur versus Fortis Hospital. This is a case when the patient had gone for colonoscopy. It was an OPD procedure. The OPD consent was taken, but the patient developed a perforation and he was taken in the operation theater. There, a different consent was taken for surgery. The patient recovered, but then he filed a case against the hospital. But unfortunately, the OPD consent was kept in a separate room, and the other consent forms and the other medical records of the patient were kept in a separate room. Where the OPD consent was kept, the room got flooded, and they could not produce the OPD consent form. So the the Fortis Hospital had to pay 10 lakh rupees compensation. So all the records of the patient should be kept together in a safe and secure place. And if they get stolen, immediately intimate the police. Keep copies of all records with you. If a request is made for medical records, either by the patient or the legal authorities involved, the same, it has to be acknowledged and issued within 72 hours. Give the discharge card transfer letter to every patient. Complete all the records before declaring death to the relatives. I've seen a case in which as soon as the patient died, the hospital was ransacked. It was a private hospital. The doctor and his wife, they did not get time to complete the records. The patient's relatives, they took away all the records and they went away, because afterwards it becomes difficult. So we try to complete all the records either before shifting the patient outside the operation theater or before declaring death to the relatives. Now this is a case of Kishan Lal and another versus SureTech Hospital. In this, the patient had undergone an orthopedic surgery and he was advised a prolonged bed rest. But the doctor did not mention about use of air bed or a water bed in his prescription. And so the patient had multiple bed sores and the patient died. So the doctor had to give 2 lakh compensation. So even the non-medical incidents, which have a bearing on the health of the patient, they have to be mentioned in the records. All the records, they should be clear, they should be correct, they should be confidential, is very important, comprehensive, contemporaneous, and in a chronological order. If any treatment facility is not available, refer the patient or call for any other specialty doctor. Now, while transferring a serious patient, transfer him in a well-equipped ambulance with a medical officer. In this case, the patient had died because of multiple reasons, and they had filed a case. But one of the reasons was that the ambulance was not well-equipped with a medical officer. If the transfer or the referral is made on the patient's request, it should be mentioned in the records. And while transferring the patient to another hospital, take into account whether the necessary facilities are available at the referring hospital. The patient, every patient, it has to be thoroughly investigated before commencing any kind of procedure, and especially when if the patient is suffering from either rare conditions, genetic disorders, or serious disorders. In this case, the Dean Lata Mangeshkar versus Sevantabai Tembune, the girl was suffering from sickle cell trait, and she was taken for laparoscopic cholecystectomy. The patient, she bled profusely, so the hospital was held liable because they had not carried out sufficient investigations to save the for the patient before taking her for surgery, and it was considered as deficiency in services. Hospital, it should be well equipped to manage all kind of complications, peri and post-operative. When you are doing a surgery, we know all the complications which we can face, so the hospital, it should be well equipped, then only undertake the patient for surgery. Always remain physically present during emergencies and don't give telephonic advices. Recently, there was this case of Dr. Pavaskar, everyone knows. This is this case of Dr. Mrs. Manika Roy, in which the patient, she was a young female who had pain in abdomen, where she was admitted in the hospital. Only the resident doctors they saw for 2 days. The surgeon, he was giving telephonic advices. After 2 days, the patient was only given sedatives and painkillers. After 2 days, the patient developed perforation peritonitis and she died. Empirical treatment should be started only if indicated and after performing requisite investigations. In this case, Varsha Gajjar versus Dr. Tiwari's maternity and nursing home, the patient had undergone a lower cesarean section and she developed fever after 2 to 3 days. The doctor, he gave a lot of antibiotics, but the patient was not recovering. So they started her on anti-malarial as well as anti-tuberculous drugs. After 1 month, when the patient was still not recovering, they went to the another hospital. The other doctor, he opened up the abdomen and a lot of pus was removed from the abdomen, and it was methicillin-resistant Staphylococcus aureus. So before giving any such kind of drugs, please perform the requisite investigations. As sir has already said that weigh the risk-benefit ratio before starting any treatment. In this case, the patient was of a systemic lupus erythematosus, and she was given hormonal replacement therapy. After few months, she developed CA breast. Never discharge a patient without dealing with post-surgery complications or complications which they have suffered during the hospitalization. In this case, the patient was taken for a laparoscopic surgery. Intubation was tried, but they could not pass the endotracheal tube, and the patient had injury to the throat. The patient even vomited blood. The patient was continuously telling the doctor that he has pain in his throat, but still the doctors, they discharged the patient. After 2 or 3 days, the patient developed parapharyngeal abscess. Always record the post-op findings and the follow-up findings, or any complaints with the patient tells on follow-ups. If any corrective action is required, please document it. In this case, the patient, Dr. Sanjay Gadekar's case, he operated laparoscopic cholecystectomy. When the patient came for follow-up, she said that she has pain in abdomen. The doctor investigated her and he found that it again required re-intervention. So he told the patient, he documented it on the records, but the patient did not listen. She went away home, and after a few days, when her condition deteriorated, she went to Bombay and she got operated. But luckily, the doctor had mentioned it on the papers, on the records, so the doctor was saved. If the patient, refer the patient to a higher center if he is not responding to the treatment. All the complications, whatever complications the patient faces during the surgery, please tell them all the complications. In this case, the doctor, he did root canal treatment and he left a needle inside the tooth, but he did not tell the patient. When the patient's pain did not reduce, he went to the another doctor who removed the tooth as well as the needle. Complication, they should be responded with accepted medical practice and at the earliest. Now, before pre-op surgery, we all know we have to do xylocaine sensitivity, MOP and instrument counting, patient identification, site identification, and side identification. Otherwise, they could lead to gross negligence. Even major risks like difficult airways, bleeding disorders, blood loss, they should all be anticipated and they should be consulted with the anesthetist. Post-op orders, they should be written by the surgeon as well as the anesthetist before the patient is shifted out of the operation theatre. As according to Boland's law, always take a course which is followed by the doctors of your profession or your specialty and not the one which no one follows. Otherwise, it can be termed as medical negligence. Always follow all the guidelines in your practice given by our associations. Our associations give us many guidelines. They should be rigorously followed. Then there are some, especially in Gynec, there are the MTP acts, BSPCP and DT acts. We should all know these acts and we have to follow them. Ensure that the investigation reports, they are not interchanged. Perform the indicated pre-surgery investigations at the appropriate time. This is again an interesting case in which the Shankarlal Dubey versus Dr. Bhavan Kue. The patient was a diabetic patient. He was taken for ophthalmic intervention. He was operated in the evening. The doctor had done his investigations in the morning, the fasting as well as the post-meal blood sugar, but he did not do the investigation just before the surgery, and that's why he was held liable. In case of death in the OT or hospital, immediately inform the police either in writing or on telephone. Always get a postmortem done. If the patient are not, the relatives are not ready, inform the police. It is their lookout. Always inform, and we have to also inform the professional indemnity insurance company as soon as possible. Duty should be delegated to competent and qualified anesthetists. Always keep checking all your monitors, oxygen cylinders, generators. Either give the maintenance to these vendors on the contract basis so that liability it can get distributed. And please give a receipt to each and every patient. If we receive a notice from the court, we have to reply it within 30 days or the decision will be given against us. And always take the help of a medical legal expert while replying to cases. Now, there are a lot of medical experts. Definitely take their help because they have a legal as well as the medical knowledge. When you go to the law, if you are consulting a lawyer, please provide medical references from the books, from the journals, and from the internet to the lawyers. Try to make personal appearances in court as and when required, and always take an interest in the case filed against you. Don't fully depend on either on your insurance company or the lawyers who have prepared the proper defense. Today's medical practice, it requires professional indemnity insurance, as sir has already said. Always be associated with a local IMA. Only they, at times of crisis, they are the first ones who are going to reach to you. Law requires proportionate degree of care in emergency rooms and operation theaters. So if the higher the risk undertaken, higher is the standard demanded by law. Now coming to the don'ts to avoid litigation. Do not take the consent of a person who is not of a sound mind, who is under the influence of alcohol or under the effect of anesthesia. Similarly, there is no need to take a consent in an emergency. Try to avoid telephonic consultation. This was given in Martin D'Souza almost in 2005. But again, after 2 years back, again, there was a new this thing. So please avoid telephonic consultation. Do not use medical abbreviations. They can be very confusing. Do not overwrite, overcorrect notes later. They can be considered as the tampering of evidence. Do not follow cross-pathy and cross-practice, and never confine a patient, dead body, or medical records for non-payment of bills. Do not give original record copies to the patient. They have to be given only to the police authority, or they have to be submitted in the court. Keep the copies, at least 10 copies with you. There should be no discrepancies in various medical records. Many times we have seen that the surgeon notes are different, the nursing notes are different, the anesthetic notes are different. So there should be no discrepancies. In such cases, definitely the judgment will be against you. Never sign anything which is left blank, any OT paper, discharge summaries, or any other documents. Many of the patients, they ask us for fitness certificates for 1 month, 2 months, but don't give them for more than 15 days. Never manipulate or fabricate the false records, and do not admit, manage a patient beyond your expertise. Do not discharge a patient prematurely before providing appropriate treatment. And if you're going out of town, please do not admit a high risk case which has chances of landing in any kind of complication till he is admitted in your hospital. And if it's urgency, please delegate the duties to an equally competent doctor. While referring the case to another hospital, don't write the name of any particular hospital. Only see that the hospital has the provided facilities. Never ignore any legal notices or summons. Please don't do out-of-court settlement with money. Many doctors try to do it, but in civil cases, as the patient can go till 3 years in the court. In criminal cases, he can go anytime. So the patients, they come with the money, and again they go in the court and file a case against you. Never plead guilty in court. Now, these are the duties of a doctor: maintain good and ethical medical practice, maintenance of medical records, You have to display your registration numbers outside. Try to use generic name of drugs and in capital letters. The fees and the other charges should be displayed outside on the board. You have to attend to the patient in every emergency. Patient's confidentiality has to be maintained, and timely information to the patient regarding his health and treatment after consultation. You have to treat the patient after he has consulted you. These are the rights of the doctors. You have a right to turn away a patient except in an emergency. You have the right to select the investigations and the method of treatment, provided is accepted by the other by your other colleagues. You have right to select the drugs. You have right to obtain a written refusal from the patient, and you have right to decide your fees. A doctor can no longer be even slightly complacent with law or protocol. So know your laws as good as you know your in-laws. Thank you.
Thank you, Dr. Rupali,
Thank you.
for letting us know how to avoid the litigations. Thank you very much.
Thank you.
Our next speaker is Dr. Govind Sethi. He is an alumni of M.L.B. Medical College. He did his undergraduation and post-graduation in orthopedic surgery from Maharani Lakshmibai Medical College, Jhansi. Then he worked at Kanpur for a few years and shifted to United Kingdom in the year 1997. There he worked in Royal Halifax Infirmary, Royal Berkshire Hospital, Burton Royal Infirmary, George Eliot Hospital, Southend Hospital. He has been instrumental in development of gamma nail also with Dr. Haldar there. Presently, he is settled at Calderate and Huddleston Field, NHS at Yorkshire. His main interest in lower limb arthroplasty, arthroscopy, and trauma of lower limb. Today, his topic will be prevention of infection at surgical site in orthopedics. Dr. Govind Sethi, please go ahead. Dr. Govind Sethi.
Okay, yeah. Okay, can you hear me now?
Yes, please.
Okay. Yeah. First of all, thank you very much, Dr. Sirohi and IMA Uttarakhand for having me as part of this webinar. Extremely grateful to you. But before I start, just one correction. You mentioned that I've been involved with Mr. Haldar for designing the nail. Answer is no. I've been there to help him to use his nail and naturally getting the figures, but the person behind the scene is Mr. Haldar. I have been using a nail, fortunately working with him in the same hospital. Right, okay. Coming to this topic, prevention of surgical site infection. It's a topic which is slightly away from your medical legal expertise, but anyway, I'll go see what justice can I do with this topic, okay? Now, this is the hospital. I work around the two sites. One is a elective. This is the elective side where we see patients for planned surgery, and this is where is accident and emergency where I do a bit of a trauma. Now, as we know, there's not much of science available for us for surgical site infection. However, over the period of time, people have worked over it, and we've come to a plan that what is the best in the patient's interest and to the surgeon's interest to minimize the risk and complications of a surgical site infection. Now, this is CDC, it's a Center of Disease Control, a society in America, which has been dealing with going for surgical site infection, and they've formulated certain guidelines to proceed and help the patient to minimize the risk. And this is an international consensus meeting which is held in Philadelphia in August 2013. There's a group of people all over the world which came together to see what they can do to minimize the risk of surgical site infection. And the third big WHO organization, they've also formulated and made the norms. However, the World Health Organization was a bit hasty in making some presumptions, and they came up within 3 to 4 months and designed the protocol. And there are 29 recommendations, and I don't think I totally agree with all of them. Some of them are okay. Maybe it's the scene because I being an orthopedic surgeon, and orthopedic surgeons slightly deal differently than other surgical specialty because the complications are dreadful and they're a bit more notorious and hard.
Dr. Sethi, we could not see your screen. Please share your screen.
Okay. I have to. Can you see now?
Yes, it is coming now.
It's coming. Just do you want me to start from the beginning? Then I would. Can you see it now?
Yes.
Can you see it now?
You can see it.
Okay, fine. Okay, so I'll just skip the first few bits. Can you see everything now? Is it okay?
Okay.
Right. Okay. Going to it, there were 3 people from bodies which we've gotten information. One, this is a CDC, which basically came from America. They designed a protocol to reduce the surgical site infection, followed by another international consensus meeting which happened in 2013. The other one is a WHO, the World Health Organization. These are a bit hasty to draw some conclusion, and they came up with 29 recommendations. Now, we don't totally agree with what WHO has mentioned. Could it be the reason that from orthopedic point of view, we are slightly more concerned with the infection side because the infections are slightly more stubborn to eradicate? I'm sure no surgeon and no patient would like to have a wound like that, and also this way. So why should we choose this topic? The reason of choosing this topic is because it's one of the 3rd most common hospital-acquired infection. Is it preventable? I don't think we can say totally preventable, but yes, we can minimize the complications, of having a surgical site infection by going through a regime. If we follow it, we're definitely going to improve our infection rate. Why? Because it increases the hospital stay. It also causes a lot of expenditure to the patient and to the trust, and so ultimately the taxpayers. It responds to more than 1/3 of the post-operative death with a bad scar and poor scar with persistent pain. Now, superficial surgical site infection, what it is been defined by various authors. Some people say 15 days because by 2 weeks or so the skin should heal. But by and large, any infection within 28 to 30 days would be labeled as a surgical site infection. It could have symptoms of, it can involve skin or deeper tissue. It may have signs of infection like different color, redness, swelling, and warmth. It may or may not have a Patil discharge. The organisms may be diagnosed or may not be, because if you started antibiotics, you would find it difficult to get a culture from it. Why say diagnosis by experience? Because if it's for me to label a surgical site infection for a general surgical, which is not my specialty, I may be failing my duties. However, we know with orthopedics how the scar will behave. So it's important that people who are in the field will be able to make assumption that is it a surgical site infection, or is it just a surgical inflammation? Now, this is the pathogenesis of the surgical site infection. We know is the contamination is basically by endogenous. It could have an exogenous or a hematogenous spread. Staph aureus is one of the most common organism which is responsible for it. It leads to proliferation of the bacteria, which induces inflammation, and you get a typical signs of inflammation, and you can identify or unidentify. Sometimes the human or the patient's response is better, so it can get resolved on its own. However, sometimes it can lead to sepsis and death. Now, we know this is a biology, microbiology, we could say. The most common cell organism is cutaneous staphylococcus negative organisms, which are normally commensal. We have been living with them from time to time, but sometimes when the human response or the patient response is poor, they can bite you and cause more problem. You can say, Gharka Vedi, Lanka Jai, that's what you can say about it, because it's a commensal. We have been friendly with it, but someday they go against us. However, other pathogenic bacteria, Staphylococcus aureus, most common, and we worry about it for the joint infection, the gram-negative Pseudomonas and anaerobes. They all are responsible for surgical site infection. The fungus is not very common. I only seen about 3 in my career, which is the cause of infection, and they're the most dreadful. So we have to be very, very careful with the fungus infection and make sure before you embark any surgery, if the patient who had a fungal infection in the past is cleared of it, and these patients who are also drug abusers or IV drug users, I found that they're more involved with fungus infection, and they're dreadful, most difficult to treat. Now, these things, how we can get over surgical site infection, it starts much, much before you operate. This is the information you need to pass it to the patient, even a day or two before a surgery is due, how to do a skin decontamination. Can you use a betadine shower? If you don't have just a normal antiseptic like a Dettol soap would be equally good for him to use it. And any chlorhexidine wipes which is available, he should use it. Now coming to the shaving, it's a very common practice. I remember when I was in India, we used to have going into the ward, maybe in the morning, so to get the trolley for my boss to impress him, get the whole part shaved right from the top to bottom, which is no more something we need to do because it's got detrimental effect, and it's been proven time after time that shaving is not good. I'll tell you what we should do in place of shaving. Now this is a skin cleansing, and basically this all of the 3 authorities, whether it's a CDC or a WHO organization, and also for the other meetings which have all come to conclusion that a soap or an antiseptic agent is good, and you should have a full bath. It's not the local. A person should have a full bath at the day of surgery if possible. Now, this slide I put is because nowadays we know about MRSA positive. If patient who is known to have an MRSA positive, 5 days before surgery should have these procedures to be used. He has to have a chlorhexidine bath along with mupirocin 2% nasal ointment, which is to be put into the nasal mucosa 5 days prior to surgery. He may not be having a wound, which is MRSA, but if he has a history of MRSA in the past, he should be using it. You'll be surprised to say that 2 to 3% of the population who are totally asymptomatic are MRSA carrier. I'll tell you the real fact, what has happened in the past. There were 2 patients in the surgery which we have performed, and 2 of the patients got an MRSA within a week's time. So we were taken to task by the infection control, myself, my anesthetist, and my assistant, and so was all the staff who were involved in the patient. We were all tested to make sure we are not carriers. Fortunately, it wasn't the case, but just to keep the MRSA is very much there, it's all around us. But if the patient who is already in MRSA in the past should have this application done prior to surgery. Now, hair removal I was talking about, there is no need to do any hair removal by your blades, We have to use what on the bottom slide is called as clippers. The clippers have to be used. Why we are taking away the shaving blade with the use with the blade? Because it causes some area of skin deepithelialization, and they may be potent for infection. The clippers have to be used just before surgery. They are not shaver. They are clippers. Maybe women's may be knowing more about it. So the clippers to be used on the local area where your skin is. If I have to operate on a knee replacement, my clippering area would be around maybe 6 inches by 2 inches wide, whatever my surgical scar will involve. Now, coming to hand washing, it's again a debatable for how long should you be doing a hand washing. Hand washing, some people will recommend for longer than normal. However, I would say for orthopedics, we should be a bit more looking into it. I prefer my first hand wash for about 5 minutes. The subsequent hand wash could be up to 2 minutes. It may vary from person to person. The International Symposium has mentioned about antiseptic on hand wash for 2 minutes, maybe more. CDC doesn't give any recommendation because they said they leave it to the individual speciality and the surgeon what they think about. However, it's important, whatever you do, even with the WHO, you must be doing it. At the end, before you start surgery, make sure use an alcohol-based hand rub. So you've done your washing, but use a alcohol-based hand rub. Now, surgical site preparation, all the 3 societies, they believe alcohol is must. you must have something which is basically alcohol based. There are preparations like what you call as a betadine, which are more like an aqueous oral alcohol. I would say aqueous alcohol has got a different role. They should not be used over the skin. Always have an alcohol based, unless and until a patient is allergic to anything. Now, we know that the contamination in the theaters usually starts when we start draping. And this picture is basically in an orthopedic department or an orthopedic theater, I would say, where we try to put drapes which isolates the patient from the anesthetist. I normally call it as a blood-brain barrier. We don't go well with the anesthetist. This is another laminar flow. There is a questionable about whether should you be using laminar flow or spacesuits. I, in all my theaters, use laminar flow. I use spacesuits only for joint arthroplasties. But any in UK, any patient who has to go have an implant put in has to have a laminar airflow. Spacesuits could be a surgeon choice, but I normally use it when I do an arthroplasty because it helps me. I've got a beard, it stops my hair falling onto the patient. So that's how I believe in it, and I go with this. Now, there have been various papers written about that should you be using a laminar flow. However, some of the authorities say there's no need of a laminar flow, but a positive pressure is important. I go with that. Yes, you have to have a positive pressure or a laminar flow for orthopedic patient. If you're using a soft tissue surgery, even an orthopedic surgeon, he doesn't need to have a laminar flow. But I have a practice of using a laminar flow for all the implant surgery. And if you look into the WHO right to the bottom, that's where I said, I don't agree with some of them. They said, do not use laminar flow. There's an abundance of literature and papers written about the microbial infection goes down when you use the laminar flow. However, there are one or two papers which I'll talk about, which says that laminar flow probably causes increases in infection, but that's based on very few papers. Now, how the laminar airflow flows is because you've got a high pressure going from the top to the bottom. It's a line diagram, which really pushes the bacteria, and the exchange of air and gases is much more evidence for patients to have minimal risk of infection. However, the film at the bottom shows a turbulent flow when you normally are not using a laminar flow. Now, this is a paper from the New Zealand, which has shown Mr. Hooper, and as you see, it says a 10-year results of a New Zealand joint registry. Why we call joint replacement with joint registries? All over the world, the Swedish were the first one to start a joint registry. It looks into the infection or any revision surgery of the patient after the arthroplasty. Now, this paper, which has been done in New Zealand, has said that using the laminar flow and spacesuit does not reduce the infection rate. However, it increases the infection rate. This is one of the paper, but this got a flaws onto it, which I'll tell you why. Now, this paper is again, which has been published in JBJS in 2016. And if you go to the bottom of the slide, where you see the conclusion, if you go to the conclusion, it says, these findings show that the patient factor remains the most important in terms of predicting early prosthetic joint infection following total knee arthroplasty. Now, furthermore, we found no evidence that modern surgical helmets or reduce the risk of PJI, which is prosthetic joint infection, and laminar flow systems may actually increase the risk in total knee arthroplasty. So coming to the take-home message, they do mention that they are not relevant. What they have not realized is that the patient which they formulated were the patients who had been having a revision surgery. And they were patients who had a complex surgery. Naturally, their complication rate of infection of a revision knee replacement are going to be higher than a primary joint replacement. Now, this is a slide which tells you about the people entering the room. As we know, the traffic in the theaters are equally responsible for increasing the bacterial count or the particle count. The slide shows the two lines. One is the flat line at the bottom. The other line, which is on the top, shows a laminar flow, which was off, and the people trying to enter into the theaters at 15 minutes interval. They found in the case where there was a no laminar flow and the patient were entering, they kept on increasing the particle count, and almost around 8 to 9, they felt it was getting worse. Now, the bottom flat line in which there's a laminar flow was working, up till 7 people entering every 15 minutes, there was no change. However, as soon as the traffic starts getting worse, even they could see there was an increase in the particle count. Now, antimicrobial therapy, you can see, as far as the antibiotic is concerned, we have to be very careful that we don't start misusing an antibiotic, which is happening nowadays, and we are really concerned about it. From orthopedic point of view, the first generation cephalosporin are the drug of choice in orthopedics. That's what people would most likely do, and that has been agreed with all the 3 societies, with International Symposium held in Philadelphia, CDC from America, and WHO. Now, when should you give antibiotic? The antibiotic should be given within 1 hour, within 2 hours, or within an hour. Again, I would differ with WHO. They say within 2 hours. There's enough evidence and papers written that you should give antibiotic within an hour. And that's what the policy I follow. The patient who has been anesthetized, they normally get an antibiotic after the anesthesia. And then by the time the surgeons are called, they position the patient. And when the draping happens, usually about 20-25 minutes before you give a skin incision. So I would prefer to follow the rule of having antibiotic within an hour, preferably close to the time, but I won't say just before you're giving an incision. Our hospital policy is to give a ticagrelor, which is 400 milligram IV, slowly just before surgery, 1 shot with gentamicin, 4 milligram per kg body weight, depending on the patient EGFR. If the patient is diabetic, EGFR is not really good, we decrease it to 2 milligram per kg body weight. And if the EGFR is less than 30, then we omit gentamicin. However, gentamicin is also avoided in case if I'm using a cement in a total joint arthroplasty. And if you're just putting an implant, a plate or a nail or the screws, you would give ticagrelor and gentamicin. If you're doing a joint replacement, just 1 dose of ticagrelor, because the gentamicin is already in the cement, because the cement what we use has got a gentamicin inbuilt. Now, what is the prophylaxis? All the panels generally agree that we should not prolong antibiotic. We should only give antibiotic for the prophylaxis. That means the antibiotic should be given only for the first 24 hours of the surgery. There's no need to give antibiotic more than 24 hours. Depending on the half-life of the antibiotic, that's what you should use. I remember in the past when I was in India, I used to give antibiotic IV for 3 days, followed by 7 days of oral antibiotic. Actually, I was treating the infection rather than prophylaxis. So there's a growing trend. We should follow the prophylaxis. And I've been meeting some webinar in India as well. I'm pleased to say things are rapidly changing in India as well. Certain conferences which I went to attend in Delhi, some of the hospitals have followed the rule and they are just going for a prophylactic antibiotic rather than a treatment doses of antibiotic, which we are normally used to. Now, this is one of the most drastic, the biggest threat to the civilization is going to be AMR. That's antimicrobial resistance, which is not too far. United States has seen the first E. coli resistance coming in May 2000 in a paper in 2016, when they found that they're getting more and more patients with E. coli resistance. Some of the papers in England and UK have also come up, and we are really very serious about thinking about it, how we can get away with antimicrobial resistance. The only way is working on a prophylaxis and trying not to misuse our antibiotic. Now, coming to the incised draping, which we normally use for orthopedics, these are dressings. After you have draped the patient on the operative area, you use iodine impregnated incised draping. CDC doesn't give any recommendation because it leaves to the surgeon and the specialty what they prefer. However, WHO is against, using incised draping, which is, again, I said, I don't agree with all of them, because time after time, paper after paper have shown that iodine impregnated draping does help to minimize the colony count on the skin operatively. So this is what you've draped the patient. If you see, it's just a pale dressing, which is a transparent dressing, which takes you to the skin. It is only placed just before the surgery. And there have been a randomized trial, and it's been found that in 101 patients who had undergoing joint replacement, they were taken cultures of the skin soon after surgery, and they found that there was 12% colonization when the user IOBAN as compared to 27.4 when there was a non-IOBAN application. Because we know the skin is never sterile. Even when you use your best of F.I.A.P, you only decrease the colony count. You cannot totally make it 100% sterile. Now coming to the wound irrigation, once you've operated, how do you irrigate your wound? There has been a growing trend of using a betadine, and here is the role for aqueous betadine, not alcoholic betadine, which is needed for preparing the skin. I use saline, the one which is organized with WHO recommends it, but it's a high pressurized with a certain device which washes the wound. But with the growing trend and the literature coming, I think I have to change my operating habits, and I will be moving towards aqueous betadine, which has to be 0.3% diluted. This is the paper which we're getting nowadays. There are 10 studies found with povidone iodine irrigation to be significantly more effective at preventing surgical site infection than saline, which is my practice, but I would be moving to, as I mentioned, to povidone iodine washout. Now, surgical site infection also has affected by the chronic patient's problem, like chronic renal, chronic liver, and chronic anemia, which has been proven time after time with different papers, when JBGS 2008, Clinical Orthopedics 2012, and so after. And high BMI, as we know, is responsible for surgical infection. And the dose response, which says is the antibiotic have to be given per kg body weight. So cephalosporin can be given up to 3 grams in patient with high BMI. So elective surgery, if you look into, it says avoid BMI if it's more than 40 for a joint arthroplasty. If you ask me, do I operate on patient more than BMI 40? I would say when I see the patient, I don't list them on day one. I always ask them to come back and see me about 6 months to 9 months time and see if they can lose weight. They have a BMI, but I call them at 6 to 9 months. If they've lost weight, well and good. If they haven't, they have to be given a warning sign that you are going to a high complication rate and for them to bear the consequences. This is a slide which tells you why patients with a high BMI got a lot of failures with a bad infection and ultimately lands to a catastrophic complication. Now, WHO has also defined 4 metabolic syndromes like obesity, diabetes, hypertension, and lipidemia, which is the cause of concern. BMI of more than 30 will be live in obesity, and some patients, maybe a time may come, we are looking into it in the NHS because it's all free to the patient. The government is looking very significantly to say that we should stop operating patients who have got BMI of 30. At the moment, it's not the case, so we're still going ahead. Now, this is the papers which does show the metabolic syndrome has been indicated as a risk factor for morbidity of total joint arthroplasty. If you have a controlled or uncontrolled diabetes, you will see a patient with a controlled diabetes, no rocket science. It means you will have a better outcome. Now, Parvez et al., he's a big surgeon in America. He's done a lot of work in arthroplasty. Even he has come to a conclusion that PJI, with my error, which is a prosthetic joint infection, the complication goes up significantly, up to 14%, which is not an acceptable complication. The complication of any implant surgery, we like to have it by 1%. Anything more than 1 to 2% is not good. So this complication of 14% is sky high. Smoking. Yes, smoking does increase the risk of infection. We all know about it. What do you label heavy smoking? Heavy smoking, more than 20 cigarettes per day, can be accounted as a patient with a heavy smoker. Definitely, I never operate patient who is a smoker, chronic smoker, heavy smoker, I would say. He needs to stop his smoking cigarette, not a week before. It has to be at least 6 to 8 weeks, and the records have shown, the papers for it, if you stop smoking 6 to 8 weeks prior to surgery, your skin and your healing is bound to be better. Now, excessive alcohol of more than 40 units per week, papers have shown that the risk of infection goes up. If patient have excessive alcohol, there's nothing wrong having a normal alcohol drinking socially. However, excess alcohol would be the cause of concern, and patient need to stop alcohol consumption. Whether they follow it or not, it's my advice. It goes into my notes, and I make them sure they're aware of it. Knowingly, I do not perform any joint replacement in patients who are smoking excessively and consume alcohol beyond the social limits. I very much documented my notes regarding the alcohol and smoking habits, and my consent always documents amputation in every patient. Now, normothermia is not so much as we talk about in orthopedics, but we do follow the norms. I was going through some literature that says normothermia is more with general surgeons, patient who's got to have some laparotomy. They've got a higher complication form of infection to their skins and scars if the hypothermia is there. However, we normally do follow the norms of normothermia. If you go to the second point, no problem with bear huggers. Bear huggers were the design in UK. It's basically a pressurized air of hot air which goes into the patient like a blanket over the patient to keep him normothermic. There have been slight concern. A paper has come from UK saying bear huggers are a cause of concern of increased infection rate, because when you pressurize it, it basically goes to the surgical field and causes an increase in particle count and the bacterial count and cause more infection. However, CDC allows to maintain normal temperature. They don't specify how. We did change a practice from bear hugger to using blank mattresses, warm mattresses. We had 2 patients in a hospital who suffered burns because the surgery took a longer time. So we moved back to bear huggers. This is what is designed by a 3M. It's a machine which pours a lot of hot air into the patient as a plastic sheet. I'll show the next slide. This is how it is. You can fold the wrap sort of a bear hugger around the patient where it's not an operative area to keep the patient warm. Now, this was the paper which came in 2011, JBJS, which said the forced air warming. On the right-hand side, you see, which is a diagrammatic, the top arrows from the top to bottom are from the laminar airflow, and the turbulence which creates by the bear hugger causes bacteria to mix with the patient operative field. Now, there are certain dressings which have been lined up nowadays called the Miplex border light. They are good dressings for a reason, but a normal practice was always we used to start inspecting a wound after 2 to 3 days, making sure there's no signs of infection. These are dressings where I've looked into the Amazon this morning. A pack of 3 to 4 dressings called about 12 pounds, which means about 300 rupees for dressing. But it's worth it if you look into it, because a dressing which a patient has to come back for a change of dressing will cost more than 300 rupees on a way. The advantage with these dressings are they are more friendly to the skin. They are stretchable. The main thing is you don't have to change it. These dressings are absorbable dressing. It will leave a small stain on the top of the dressing. I normally do any joint replacement. I might see a small blood stain, which gradually gets blackened over the second day because it's clotted. You can go and see the patient after 2 or 3 days. If the dressing or the redness or the fluid or the exudate is not increasing, there's no need to change the dressing for up to 10 days or 2 weeks. It minimizes the epithelialization, which you normally disrupt at the time when you change the dressing. And this is also come with silver impregnated. As we know, there are different layers of it. It's an absorbent. It allows stretching. There's no signs of blister formation, and it's got a silver nitrate. You may choose to use silver nitrate or not. It comes with or without silver nitrate, but I think the cost is not much. It used to be very expensive. It's come down over the period of time. The advantage is you can leave the dressing up to 10 to 12 days before you have to inspect the wound. Now, in conclusion, I would say prevention of surgical site infection is everyone's responsibility, right? Starting from the patient, a disciplined life, to the surgeon, as well as the hospital. All stakeholders are responsible for it. A bundled approach or a wrong way of doing it may affect the patient's outcome. And it's based on all best available evidence. So I'm sure if you take all the precautions, everybody would like to get a scar of a neat and clear scar like this. At the end, I would say greetings from Halifax, where I come from. And I'm sure the Diwali is not far. Happy Diwali to you all. And have a safe Diwali. Thank you.
Thank you, Dr. Sethi. Thank you. Such a nice talk for this horrible subject, because every orthopedic surgeon is very much afraid of infection, especially in the clean cases. So I hope this will go a long way for the audience. Now we are coming to the last topic, and Dr. Rakesh Mittal from Florida, USA is our last speaker. He is an alumni of SN Medical College, Agra. He did his M.D. Medicine from SN Medical College, Ph.D. in molecular biology from University of Newfoundland, St. John's, Canada. Now he is settled at Florida, USA. In between, he has got many things to his credit: his professional experience, hospital privileges in St. Petersburg, licenses, certificates. These are some things which I would request Dr. Rakesh Mittal to carry on with this topic today. The medico-legal litigations in nursing homes in USA. Dr. Mittal, please.
Yeah, hello everybody. Let me share my screen first. The reason I chose this topic is I do a lot of my practice is nursing home based, and I do a lot of hospital work. So I thought, given the organization that everyone belongs to discuss some medical, legal, and ethical issues in nursing homes here. Let me see if I can get this slide. I think you can see the slides, right? Okay. So the topic is the medical, legal, and ethical issues in nursing homes. And as you all know, physicians who provide care in nursing homes are regulated by ethical and legal issues. And because of numerous complex regulations and multiple complex medical and social problems. I need to get this screen full screen. Let's see. Where do I do this? Oh, slideshow. There it is. The frequently encountered issues in this context are advanced directives, competence and decision-making, decisions about life-sustaining treatments, resident abuse, restraint, psychotropic use of psychotropic drugs, and risk management. It is therefore in this framework to have the knowledge of the legal and ethical framework and understanding of these complex issues, which helps us to better care for our patients. The first thing is, who is the nursing home patient? In the United States, they're predominantly poor, elderly, physically or mentally disabled. Now, one must ask, well, how come they're poor? Well, they only qualify for long-term nursing care only if they have a certain amount of income. Otherwise, they don't qualify, and they will have to pay private pay, which could end up being $6,000 to $7,000, $8,000 a month. 63% of these nursing home patients have some type of cognitive impairment that may affect their ability to fully make decisions or participate in this. In this regard, autonomy and self-determination is fundamental in medical ethics, the law of the land, and basically daily lives of most Americans. And therefore, becoming a nursing home resident also means leaving a certain amount of autonomy at the door. It is not easy to move from a family setting of independence to a nursing home, and that confirms and adds a new dimension to the loss of autonomy and self-determination. Most decisions in the nursing home are made by somebody else other than the resident, and it could include physicians, dictated by nursing home policies, a lot of local, state, and federal laws and accreditation standards. Unfortunately, it's very difficult to provide personalized care, privacy, and autonomy in a nursing home, and creates numerous medical legal issues. In 1987, regulations were passed to address resident rights and welfare in the Nursing Home Quality Reform Act, also called OBRA 1987. And it assures residents rights to privacy and decision making, maintaining confidentiality of personal and clinical records, requires comprehensive resident assessments and individualized care plans, ensures proper use of physical restraints and psychotropic drugs, ensures a minimum amount of nursing care provided to each resident, and social worker coverage. It requires notice of patients' rights to be provided at the time of admission, implementation of admission policies of each individual nursing home, and ensures transfer and discharge rights to the patient. The ethical principles, issues of confidentiality, consent, and assessment of decision-making capacity are all part of physicians' everyday life here in US. Principles of beneficence, respect for people, fidelity, and justice are all used as a framework to approach any ethical issue, and I'll go what they mean one by one. A principle of beneficence refers to the obligation of doing what's best for the patient and to do no harm. Occasionally, conflicts with may arise in situations which of what will not cause harm and what is best for the patient. Autonomy is one of the most important aspects in consideration of informed consent, disclosure of information, making healthcare decisions in advance, and the right to refuse treatment. Although difficult to personalize care schedules, attention for each individual patient, attention to small details sometimes makes a big difference in helping us. Another aspect of respect of people is constituted by respectful action, especially in patients who suffer loss of cognitive capacity. This includes concerns with how patients are addressed, handled, clothed, and treated during any interaction by the caregiver. Principle of fidelity embraces the all-important doctor-patient relationship, trust, confidentiality, and principle of justice addresses equal treatment and distribution of resources. However, justice sometimes poses special difficulty because it can conflict with fidelity or beneficence treatment. Decision-making capacity, competence, and consents. Most nursing home residents have limited ability to make personal and medical decisions because of cognitive impairment and communication. However, limited decision does not necessarily mean that residents are unable to make decisions. Residents sometimes may defer decisions to trusted family members, even when they retain the capacity to make decisions. Even healthcare providers, therefore, must consider and evaluate competence and decision-making capacity as separate entities. Many residents with cognitive impairment have variable abilities to make decisions. In reality, many patients with cognitive impairment have variable abilities to make decisions, and variability can be expressed as decision-making capacity and could be partial and may vary from time or any given situation. Healthcare providers must provide weigh the benefit burden ratio of possible life situations in nursing homes surround life and death decisions for individuals who are functionally incompetent and have no family or friends to share residents' views or wishes. Legal guardianship and consultation with ethics committee may help provide appropriate action, and sometimes we use healthcare surrogates. Persons who serve as healthcare surrogates should agree to do so, know the resident very well, enough to bring his or her goals and values to the discussion, especially in the absence of advanced directives. This is more pertinent in end-of-life care, and not necessarily they provide a big role in day-to-day care of the patient. And other important thing is the physician and the surrogate should agree on patient's best interest. Advanced directives are very essential and includes a living will or a durable power of attorney for healthcare, written legal documents to guide medical care, especially in end-of-life situations. Since most nursing home patients are elderly, they're more likely to die there, and therefore it is pertinent that both formal advanced directives and informed decisions regarding end-of-life care be addressed with the resident, their surrogate, healthcare proxy, or durable power of attorney. In the US, there's a Patient Self-Determination Act that requires all medical facilities, including hospitals and nursing homes especially, to ask if the prospective resident have advanced care directive documents. Now, decision about life-sustaining treatments, conversations regarding advanced Medicare medical planning should specifically address desires for life-sustaining treatments and initiate discussions of withholding or withdrawing treatments in situations of terminal illness. The principle of autonomy dictates that competent patients choose among medically indicated treatments and refuse any unwanted treatments. However, limitation of treatment does not necessarily imply an all or none phenomena and can be specific. So a patient may choose to, for example, be a do not resuscitate and or do not want to be re-hospitalized, but would want antibiotics if they get a pneumonia, or if they get a UTI, they want to be treated. So they can be very specific at what they want or what they don't want. All this has to be documented in the medical records. While it may seem more difficult to withdraw treatment than to withhold it, here there's no difference in either one of them from ethical or a legal perspective. Protection. While issues of decision-making addressed previously focused on autonomy, several issues in nursing home care emphasizes protection of residents. Healthcare providers, families, and friends must appropriately balance the patient's right to act autonomously in a manner that may be harmful and moral responsibilities to protect the vulnerable. And it addresses issues like restraints, use of psychotropic medications, abuse of residents, risk management, and ethics. And I'll go through them one by one. Restraints. Mechanical restraints have been commonly used in nursing homes to protect the resident from harm and minimize risk for the institution and other residents. However, there's a growing evidence that restraints do not minimize risk to the institutions and can actually cause more harm to the one restrained and may be misused by as a form of convenience or discipline by the nursing staff who's unable to provide sufficient care to the residents. Restraints can cause physical harm, including ischemic limbs, contractures, skin trauma, deconditioning, and in the past, we used to use cages in the hospital setting for a very violent patient, and we had a case of asphyxiation. Those are all banned right now, and it also causes significant psychological morbidity, including humiliation of the patient, fears, stress to the resident, and demoralization. Since 1987, the OBRA Act have significantly decreased the number of residents who are restrained. And back in 97, it was of almost 59% of people were restrained. In 1992, 22%. Today, it's almost negligible. As a matter of fact, in nursing homes, specifically nursing homes, restraints are not allowed. Even a bed rail is considered as a restraint. because it takes away the right of the patient to get out of bed. A lap band is a restraint. Even a food table, a food tray in a wheelchair is considered a restraint. And so those are not allowed. However, they come with their own problems. Patients have to be watched closely. There are frequent falls, and but most rehab centers that I go to do not allow restraints. Hospitals still allow restraints, especially some of the hospitals I go to. We can use 2-point restraints to the hand. And lap bands, but no cages or anything. Alternative therapies are preferable to restraints. Prompt treatment of medical problems, for example, a bad UTI causing confusion, agitation, you treat that. Environmental safety concerns, for example, patients falling on the floor, so have fall free or slip-free floors, and behavior modification techniques. Sometimes a patient is agitated because they are unable to talk to their family members, so you make a phone call, let them talk to them. Sometimes patients may trust a particular aid in a nursing home much more than anybody else, so we provide that aid to take care of that patient. Psychotropic medicines, again, have been commonly used in nursing homes to protect residents by controlling a variety of symptoms and behaviors. And they include psychotropics, tranquilizers, and anxiolytics. However, prior to the OBRA Act, almost 44% patients were being given psychotropic agents. And as you all know, they have life-threatening side effects, including sedation, frequent falls resulting in fractures, extrapyramidal side effects like tardive dyskinesia, worsening of their cognitive and behavior condition, and medical conditions and cardiovascular side effects. At this present time, we can only use neuroleptics or psychotropics only if they have an appropriate psychiatric diagnosis, and otherwise we can't use it. Anxiolytics and tranquilizers are still used. Antidepressants are still used. We cannot write any neuroleptics or psychotropics on as needed basis. And every single month, we have to have a plan of continued use of these medications if we use them, and a gradual reduction is warranted, coupled with attempts at behavior modifications, including environmental modifications. I'm a medical director in a rehab center, and every month we have what we call as a medical directors meeting, where the clinical pharmacologist would be there and making recommendations to say, for example, patients has been on this medication for the last 6 months. Please address gradual reduction or justify the use of it, and and it has to be documented in the medical record why you're not reducing it, or the continued use of it. Abuse of residents is not uncommon. Physicians obviously have an ethical responsibility to uncover, report, and address abuse of residents, including willful neglect, as well as physical, financial, psychological, and sexual abuse. These include abuse inflicted by nursing home staff. It could be visitors or even other residents. Nursing home residents are particularly vulnerable to abuse, not only because of their physical and mental dependencies, but also fear of reporting it. They fear that if they report it, they'll get less care. When physicians suspect abuse, we have the primary responsibility to ensure the safety of the patient, perform a thorough physical exam, historical review with the resident, document their findings, and report it to the appropriate authorities. We've had cases like this day in, day out. For example, not too long ago, I had a patient who was schizophrenic, was hallucinating and delusional. In the middle of the night, she will see shadows in the room, and then complained to the director of nursing that someone was sexually abusing her. The complaint generates a series of things. I'm informed as the medical director and the primary care provider. I have to come in, evaluate the patient, and do a thorough physical exam, document my findings. The authorities or the administrators have to immediately inform the state, what we call as ACA here in Florida. The state representative would investigate it, call me, get more information. Every complaint, even if it's fictitious, has to be accounted for and is reported. Currently, 42 of the 50 states in US have mandatory reporting laws for even suspected abuse. And all states have some system for reporting abuse through Adult Protective Services. Here in Florida, we have the Department of Child and Family. I had a patient just maybe 2 months ago, my office patient, cared by, he's legally blind from glaucoma, cared by her daughter. One of the nephews who was unhappy, complained to the DCF about the daughter that she's abusing the patient. Next thing I know is I get phone calls from an investigator, and because of the coronavirus, I hadn't seen him in almost 7-8 months. They were locked down. And so immediately had to make an appointment. The daughter came with the patient. I had to examine, document any weight loss, any uncontrolled diabetes, any evidence that the patient has been abused and or not, and document that and then report to the officer who called me that I didn't see any evidence of it. And then they they either close the case or monitor it. Risk management is therefore very important in practice in a nursing home. The principles of beneficence dictates that clinicians should be aware of and participate in the development of policies that directly improve patient care while preventing harm and minimizing risk to the residents. This happens pretty much every month in a medical directors meeting where we identify situations, put corrective actions in place, and this could include frequent communication among physicians who may be taking care of the patient, nursing home residents, families, combined with thorough documentation to prevent any claims or misunderstandings. Most of the sources of lawsuits in nursing homes is because of professional negligence, medication errors that happens all the time. However, with today's electronic scanning, we scan the medication. Each medication has a barcode. Patient is scanned, the medication is scanned, and dietary mistakes can happen. Patient with dysphagia and who was supposed to be on a nectar-thick diet and by mistake was given clear liquids, now aspirates. That's a medical lawsuit. Allergic reactions, infections, improper physical or mental assessments, improper transfers or discharges. Pressure sores is a big one. Lack of informed consent for treatment and withholding or withdrawal of life-prolonging treatments or refusal of such a request. Therefore, incident reporting is very, very important and is always done. Nothing is hidden. Is useful to many ways to identify adverse occurrences when there's an unexpected poor outcome or death, and subsequent actions can be valued in an individual case to identify, investigate, and correct adverse trends and implement corrective actions. A good example in a nursing home setting would be we document everything, for example, how many falls happened this month, how many people are on anxiolytics or psychotropics or antidepressants. We present that. For example, nursing homes, these are large facilities with many wings. If we identify more falls in a certain area than the other, then we find out why those falls happened. Was it because of a certain aide who didn't pay attention, or was there not enough staff there? And corrective actions can be taken. All this data is reported to the state authorities on a monthly basis, and that's how nursing homes here are rated from 1 to 5. And star rating is very important because patients have the right to choose which place they go to. Then there's ethics committees and consultations. Nursing home care is very much constrained in many, many ways by so many laws and regulations. It's like a stack full. You could fill 10 boxes of regulations. I don't have to deal with most of them other than in our monthly meetings for corrective actions or my opinions. Yet most ethical issues in nursing homes, they're best resolved in an open and thoughtful discussion among the resident, relevant family members, and the physician and nursing staff involved in the care. However, oftentimes the physician may not know the resident very well or have conflicting values and may pose decision-making dilemmas. And in these situations, many nursing homes and institutions are turning to either committees called ethics committees, or sometimes if there's a conflict between the physician, the family, and the patient, then we get a second opinion. And with that, I close my talk. It's very complicated in nursing homes here. And anything can generate a problem. I'll give you examples of, for example, I had a patient with cardiomyopathy who was bradycardic, has paroxysmal AFib, was on multiple medications, amiodarone, beta blockers, and DIG, became bradycardic, fell while the nurse was taking her to the bathroom. She fell, broke her shoulder, and she fainted. The nurse immediately started CPR. Within 60 seconds or 90 seconds, I was told that the patient just woke up and was sent to the hospital. The question, there was some question somewhere in the document, whether it was by the EMS or the rehab center itself, that the nurse did not check pulse before doing CPR. And that became a big issue. Here we go, a meeting was, I had to meet with the nurse, look at the documents of exactly what happened, and basically have to document, which was true, that the pulse was so feeble that the nurse wasn't sure if she had a pulse or not, and therefore CPR was started. X-rays were done, and there were some rib fractures as well on the right side. And then another problem came in. I got a call that we got to find out if these fractures are old or new. Now I have to dig old records, get repeat X-rays and CT scans in the hospital setting for the radiologist to say, well, these are old fractures. So every little detail and every little thing that we do in rehab settings is a door opening for a lawsuit, or and it has to be reported. That's the problem. They have to report it. Now it will be investigated, it will be addressed, and most of the time, I mean 99% of the time, cases are closed. I had another patient, for example, about a year ago, still in the rehab center, but she's a patient morbidly obese with obstructive sleep apnea on oxygen on a Trilogy BiPAP machine. She has chronic respiratory failure, chronically hypoxic, hypocarbic, was getting really lethargic. One of the nurses, while dispensing medicines, accidentally and mistakenly gave one pill of Dilaudid to the patient. Patient was already lethargic and sleepy. So that one pill of accidental Dilaudid just opened up a big problem. It had to be reported. Patient was getting more lethargic. Patient was sent to the emergency room, placed on a regular BiPAP machine. Within 10 minutes, she woke up. In the rehab center, I had to give her almost three doses of Narcan, and the patient didn't wake up. So obviously it wasn't because of the Dilaudid. It was because of hypercarbia. Her PCO2 was over 100. Now, because that patient was on BiPAP, she was sent to the ICU for observation. Guess what happened? The case managers in the hospital reported it. We reported it in the rehab center, but the case managers reported it as a neglect or medication and a medication error, which it was obviously was. I had to document tons of things to justify that the Dilaudid is not the one that made the patient go into hypercarbia, and because she was already in it, and Narcan didn't reverse it. I got a call from the state investigator, and I had to explain the whole thing. And this is to not only protect us, but the institutions, that they did not do anything wrong. But so it's very complex, everything is so well documented in the charts. We use electronic records, so once signed, you can't change it. You have to put addendums to it. It's very challenging. And with that, I'll thank you for your time, and I thank Anurag, who invited me to present this, and that's it.
Thank you, Dr. Rakesh. It's really, you are working very much constraints there. We are thinking that we are having here a lot of laws, but in USA, I think there are more than this.
Right. And lawsuits are not very, they're not very, very common. I mean, obvious negligence is different, but documentation is the key. There are gold diggers everywhere. There are gold diggers here too, but it has to be substantiated, and so it's all investigated and reported, and that's the good thing about documentation, that you document every single detail, and so that, because you never know, there's a there's something called discovery. So even if they discover something 2 years down the road, it's the statute of limitation is 2 years from the time of discovery. So I've had colleagues who were sued 7 years later because they discovered it 7 years later. Now, if you have proper documentation and all that, then you can defend it. But documentation is the key. Unfortunately, we spend a lot more time documenting stuff in the United States than we spend time in seeing patients, or and this is a really sad thing. It is a real problem, and somehow people here found a way of to document everything, which is very important.
Okay, sir. I would request you to, sir, stop sharing your screen so that we can have a panel discussion.
Oh.
On top side.
Oops.
Top side of your screen. Yes, yes. Thank you, all the speakers. So now I would request the panelists also to join along with the speakers, and I would request Dr. Himanshu, if he has any questions from the orthopedic surgeon, Dr. Govind Sethi. Dr. Himanshu is working at Max Super Specialty Hospital, Dehradun. He is an orthopedic surgeon and a postgraduate from Rohtak. Dr. Himanshu, please unmute yourself.
Uh, this is a nice discussion regarding the medical legal issues, and there are not many medical legal issues which are on rise. So I would say that that we are living in a litigant society, and every patient is a potential litigant. Like this, we should remember all these things. And as there are many ways to the god, and there are many the approach to the same thing maybe varied from one person to other. So we should also stop criticizing our colleagues regarding the modality of the treatment they have chosen. My specific question is to Dr. Sethi is regarding the infection. In your setup, how much culture negative cases you encounter? As per literature, it is around 10%. And how much culture negative cases you encounter? One. Second, if you have to take the cultures, what is the duration of the cultures which you take so that you can catch the bug? Because that if you catch the bug, that is the best chance for the cure of the disease. These two questions to Dr. Sethi.
Yeah, thanks for asking this question. One has to be careful, that's what I said. My first slide is look into it. There was a slide saying about individual patient experience. I'm sure you being an orthopedic, there will be patients we put into blood thinners, you see, or on a DVT prophylaxis for any surgical intervention. And then a decision has to be made whether it's a wound leakage, the vein circuit, or as compared to, if it's infection or not. So important thing is don't jump on starting giving antibiotics. If you're suspecting, naturally, you have to start looking into a CRP. A CRP is going to be raised anyway in the first surgical after that. But you have to take a CRP, which becomes your baseline. Maybe the CRP is 250, which is sky high. But then after a day, take another. If the 250 starts becoming 280, 300, you have to start suspecting. But if you give an antibiotics, make sure sometimes your cultures will be negative. To get the culture, we need 48 hours. But what we normally do is we keep an extended culture. If the patient's culture is negative, then we don't look into that. We try to see if I can get another culture in the next 24, 48 hours. So the culture is 48 hours. If the patient has got high rising temperature and you're feeling there's an induration getting worse, then I think the culture is not always what you should go with. You have to open the wound and wash it together before it's too late. Because as we know, the patients develop a biofilm, which is something which is not susceptible to antibiotics. I would say culture time, 48 hours. Sometimes you look for an extended culture, but if the culture is negative, doesn't mean you can sit on it. Because a lot of patients who come as a septic arthritis of the knee, the knee is swollen, clinically it looks like septic. You aspirate the knee and you will be surprised. It says there's no organisms. But if clinically he's losing his appetite, the temperature is going up, you need to wash the knee. So the clinical judgment is important. So 48 hours for the culture. If they are negative, we're suspecting it, go for extended culture. And you take the culture in a broth culture, which gives you more extensive time to diagnose it.
Yeah, thank you. Yeah. I
Is it
agree, but in India, like you
Yeah,
are saying 48 hours, but in India, when the patient arrives to us,
yeah,
usually the antibiotics, like most of the clinician, if you ask in India, what is
yeah,
the duration of the antibiotics you give? Yes, the trends are changing, but still people give the oral antibiotics in their discharge summaries. And the dictum that you have to give 24 hours before and 24 hours after in the clean surgery. And
yeah,
then like very few surgeons or very few centers are following this. Even in the very busy centers, we have seen that the antibiotics are given in the discharge summaries also. And once the surgeon suspects infection, or usually they start empirical antibiotics, pretty broad spectrum antibiotics, and then the patient usually reports to us. Even if you stop the antibiotics for 2 weeks and you culture them, you don't find any organism in that. And like I'm quoting Mr. Trapezi, he has come up with the practice guidelines for the PGI, that is the prosthetic joint infection. In that he states that if the cultures are negative, you can go for the prolonged cultures for 5 to 7 days to identify the bug if there is any.
yeah,
And
yeah. That's the extended. What people have to understand is, I'm sure in India, if you do a soft tissue surgery, you will give antibiotic, isn't it? The way to start is stop giving antibiotic in where you don't think there's a need for it. And I'm sure you will be covered legally because the literature supports you. But definitely don't start giving antibiotic too long. And when you get a patient who's already on antibiotics, you are going to bound to get a negative culture anyway. So the antibiotic have to stop, preferably 48. The best is 5 days before anything of a culture you take. So if the patient is already on antibiotic, you're bound to get a wrong answer for it. You see.
Yeah.
Dr. Rakesh, I have a question for you, sir. What
Yes.
is the law about euthanasia in USA?
What is the what?
Euthanasia.
About euthanasia.
Mercy killing, euthanasia.
Euthanasia. We don't do that, but in terminal cases, we have a service called hospice. Usually in terminal illnesses, and the patient is terminally ill, the family or the patient may have advanced directives, uh, which would state, do this, do that, do this, intubate me, give me nutrition, give me not nutrition. They have spelled everything out in a form, and that's advanced directives, and we follow it. But there is nothing called euthanasia, but service called hospice. And a lot of patients or their family members may choose a hospice service. For example, in a patient with lung cancer, stage 4, metastasized everywhere, and hospice, what they basically is what we call it comfort measures only. It's a specific order that you have to write, comfort measures only. And that comfort measure only means making sure they have enough pain medication. These are not lethal doses. They're meant for comfort. Similarly, we can use lorazepam if there's a lot of anxiety. We use various medications to reduce secretions, and then let the patient die a natural, comfortable death. But euthanasia would imply give a lethal dose of something and end it. We don't do that. It's a more compassionate way of helping people die by utilizing services like hospice, um, and that's what we use here.
So you were talking about withholding some treatment or withdrawing the treatment. So that does not amount to euthanasia.
Now, patients have the right to refuse treatment. A lot of times it's a physician decision. For example, patients very early on when we see them, we ask these questions: how much aggressive do you want us to be? Uh, it's really based on patient to patient. For example, um, just because you can do something doesn't necessarily mean it would be the right thing to do for the patient. So in that case, you can call it withholding treatment. It's like, why would you do a 90 open heart surgery on a 96-year-old? You want to so a valve replacement. Yes, you can do it. So you're kind of withholding treatment because it's not in the best interest of the patient. But I'll tell you, I've had situations 7, 8 years ago. I had two 96-year-old patients. They were functionally very good, um, intact brain and everything. This 96-year-old had the only problem she had was she came in with decompensated congestive heart failure from a critically aortic stenosis, and she failed medical treatment. She would not get out of CHF. So I call a cardiologist. We do the right and left heart cath to determine how bad the stenosis is. And then I actually call a surgeon. One of my cardiothoracic friends in one of the hospitals, very fast surgeon. I said, hey, Joe, how fast can you do a aortic valve? And he said, Less than 10 minutes. I said, I have a 96-year-old, and he went, are you crazy? I said, hey, go see the patient. This patient behaves like a 70-year-old. She's very functional, mentally and physically, and the only problem is a valve. She has clean coronary arteries. Guess what? He did open heart surgery on that patient. And to date, that was the fastest discharge I had from the hospital. In 3 days, she was out of the hospital, dancing around. So, decisions about withholding treatment or uh, uh, or withdrawing treatments in, in in the eyes of the laws and ethics is the same. Decisions are made on case-to-case basis. And the primary denominator is the best interest of the patient. Sometimes we make decisions about things. For example, just 3 days ago, the patient who fell had a broken shoulder, distal clavicular shoulder. She was so thin, the clavicle, and there was a AC joint separation. The clavicle was sticking out of the skin, almost sticking out, and the surgeon was like, well, I got to take it out, otherwise it would erode through the skin. I called the son, and he didn't want surgery at first, but then I explained to him, hey, listen, in a few weeks, this bone is going to just erode through the skin, the joint will be open, and she's 40 years old. He understood the consequences and everything, and put her through surgery. So in that case, initially it was uh, not giving her any treatment, but then we ended up doing it in the best interest of the patient. And so, as far as withholding treatment, it's like, well, a progressive dementia patient who's progressively having renal failure. What's the point of giving them dialysis? And after discussion with the patient, the family members, and most of the time families are involved in this. Most of these patients have healthcare surrogates or durable powers of attorney, and they're very comfortable. We don't want our mother to go through a painful procedure or dialysis. On the other hand, there could be a patient already on dialysis, but progressively getting demented and went into septic shock. And now the family is making decisions. There's no point continuing dialysis at this point, and we stop dialysis. So a lot of times these decisions go very smoothly. People here do not have a problem letting people go, especially elderly, and they do understand the risks and benefits. We have to explain it to them very, very clearly. More than that, it's documented. Everything is documented. So they can't come back to you and say, well, I didn't say that, or you didn't say that. And so there's usually never a problem. Very occasionally, we end up in uh, problems that could lead to legal issues.
I think one thing we'll add, if you could remind me, because as you said, Dr. Sirohi, we normally have what you call as a DNA CPR. That means the patient who is, as we were talking about, the patient gets a treatment. But on the notes, it goes as a DNA CPR, means do not actively cardiopulmonary resuscitate. So that doesn't mean that you're taking away the treatment away. Should an event happen that the patient has got to a stage, you will not resuscitate and you won't be taken to the court because, as mentioned, we have discussed with the patient, with the relatives, and somebody who's 90, 92 years, there's no reason for to resuscitate or patient with terminal cancer. However, he may be young as well. We know the life expectancy. If he's not going to go do well, that is not euthanasia. We are not debarring over the treatment. We'll give him symptomatic relief and comfort. When it comes to life saving, we will not go for that, like a cardiopulmonary. So that is DNA CPR, which is not euthanasia, but is added on the forms. So do not actively resuscitate. Make them comfortable.
Yeah, and sometimes here we have what we call as DNR, do not resuscitate, and DNI, do not intubate either. But I've had situations where patients' family members would not want either one of them, but will be okay with chemical resuscitation. Doesn't make sense. Some hospitals do not allow limited resuscitation, like do the chemical resuscitation, but do not do CPR, and they don't allow that anymore. But in the past, they would, what we call as limited DNR. DNR, as Dr. Mentioned, that it doesn't mean do not treat. And DNR is revocable. In other words, if there's a chance that the patient could survive, I would call the family members and say, rescind the DNR. There's a chance that this patient can survive, and they would. They may end up getting intubated, but then they have a choice, because they're legal power of attorney, to then make them DNR. And so DNR is revocable here, and you can go back and forth. It's not an issue. One thing is, if a patient is do not resuscitate, if they happen to go to an operating room for any reason, the DNR is automatically rescinded by law. You cannot be operating on somebody who's do not resuscitate. Soon after the operation, the DNR is reinstated. And I'm sure in England it's the same thing. I don't know, but you can't have somebody go to the operating room or any procedure. Any procedure. It could be an EGD. It could be colonoscopy. It could be anything. It's automatically rescinded.
I think we, like neck of femurs, elderly age group, we have got patients who are DNA CPR, but we take them to theater for trauma. With the trauma, because if they don't operate, they would die anyway. But definitely, as I said, it can be changeable. But we do have DNA CPR in position for an elderly age group patient who are frail, and we will take them to theater, operate on them for neck of. We may not do elective, like for example, planned surgery, but DNA CPR we do operate on trauma to make them comfortable. Again, the reason doing it, make them comfortable.
Yeah, and that's exactly right. I've had many situations where patients with ischemic cardiomyopathy, EF of 10%, severe aortic stenosis, happen to fall, break a bone, and they're in severe pain. Very rarely, but we have done open reduction in tone fixations. Could be as simple as a pinning to relieve pain, and that has happened too. Not necessarily for the purpose of prolonging their survival or life. It was mostly for comfort. And family members occasionally have done that. And we do that.
Dr. Rupali Jain,
Yes, sir.
are you there?
Yeah. Yes.
I would ask you a question, ma'am, for the benefit of our audience and myself also. What's the best way to handle a DOT, death on table?
Death on table. Okay. Death on table, it's a very scary issue. And you have to manage three things. First, you have to manage medically, socially, as well as legally. Medically, of course, we will definitely, we know what all things when the patient starts deteriorating. I won't talk on that. But socially, first of all, we have to be very soft and gentle with the relatives. We have to handle them well before disclosing, while disclosing the death. Then legally, now the most important point today which we are discussing is the legally. Now, as soon as the death occurs, please complete all your documents. Please complete all your records as soon as possible. Though we have to give them within 24 hours, but still I would say that please complete your records, and all the records, they should match. As I've already said, the anesthetist record, the surgeon's record, the nursing notes record, they all should match. You have to immediately then inform to the police. Either you inform him in writing or you can inform on the telephone. While informing on the telephone, note down the batch number of the police officer, whoever you have informed. Then the police, they will come to your hospital. So whatever injections or you have given to the patient, whatever drugs, all just take them separately, put them in an envelope. All the broken vials, they should be put, because while doing the panchanama, the police officers, they would ask you to for that the vials.
Madam, who is the best person to divulge the death to the patient's relative? Should the doctor himself do it, or the operative
Yes, I think
surgeon,
the
or
doctor
any
himself,
operative
sorry,
surgeon or analyst?
I think the operating surgeon only should do it, because who has seen the patient, who has handled the patient, I think he would be the best person who should be the disclosed, because the patient's relatives, they have faith on that particular surgeon to whom they have taken their patient. So I think the operating surgeon, they should handle, or the operating physician, whoever is seeing the patient, they should disclose it to the relatives.
Dr. Jaggi wants to say something. Dr. Jaggi.
Hi, Dr. Rupali, I'll address you this question once again. Thank you very much for your very crisp and fluent talk. Uh, just an extension of Dr. Sirohi's question. So we have a situation when you have a brought dead patient, dead on arrival. So what are the do's and don'ts then?
Okay. When the patient is brought dead, first it's the physician's duty to declare him dead. So first he will do his ECG, or maybe he'll record his pulse oximeter, whatever. So I think the doctor, I have seen some doctors, they just send away the patient, but it is not a right practice. They should maintain all the records. They should, if they have taken an ECG, the doctor, they should keep one copy of the ECG with themselves, and they can give them to the relatives also, but one copy should be kept with the doctor. And I feel that there should be a register maintained in which all these brought dead patients, it should be entered there. If the patient, the relatives, if they are asking for a death certificate, please don't give, because you don't know the cause of the death. If they are insisting, then ask them to get a post-mortem done, and then only according to the post-mortem report, give them a death certificate. Otherwise, don't give.
Is it necessary for if a patient is brought dead here, and the relative says that, oh, his death now, we want to take the body. So is it necessary to inform the police, or we should allow him to take the body?
I think
If you
I'll enlighten you on that.
Okay.
Can I intervene?
Yeah, sure. Sir.
Okay. So what I want to say is, whenever a patient is brought dead, so you have to first suspect what was the cause of the death. So
Yes.
think the cause is hanky-panky, you feel something wrong, you have some body marks, you feel it could have been because of poison or any other issue, you have to inform the police immediately. So that is very
Or a
important.
road traffic accident also.
Of course, you have to inform the
That
police.
may be also cause.
Yes, and the second thing, supposing that it is a patient who was being treated in the same hospital for some benign other disease, like he had a renal failure or a cardiac problem, and if he is brought dead, then it is the discretion of the attending doctor to give the body to the patient and let them go. And even if he was being treated in the hospital, they can even issue a death certificate. That's my take.
Yes, sir. Definitely.
Dr. Anurag, what do you say?
Yeah, in cases where some foul play is expected when the patient or any body is there, any patient brought dead, then the doctor must inform police. This can be a cognizable offense committed.
Yes, sir.
Never know.
Yes.
So in this case, I think if nothing is suspected, it's not mandatory to inform police. If doctor is satisfied that
Suppose it's an old patient.
and already it was in the care of the doctor and he knew the prognosis. So
One thing,
Now,
one,
someone who comes in dead, who issues the death certificate, or is there anything called a death certificate there? Because you wouldn't allow funeral without a death certificate. So is the physician who's seeing the patient dead on upon arrival? How do they do a death certificate? Or if they don't know the patient, they don't know their history or whatever. Is there any mechanism there to death certificate? What do you put on it?
Dr. Jaggi, please.
what I said was, if the patient has been regularly visiting the same hospital for a particular disease, and then he was brought dead, they can correlate the same thing
Right.
put it in the record and issue a death certificate. Another way of getting the death certificate from such type of patient is from the last treating doctor who was
Yes.
treating that patient for some ailment. The last treating doctor, if they have the prescription, they can go to him and get a death certificate. And the last option is go to the police, get a panchanama done, and then that's what we have it in India. And you get that copy of the panchanama, then you can cremate the body.
The same thing we do here. If a patient died at home and the police officers, they call me and they say, well, are you willing to sign the death certificate? I know the patient, I would say yes. You do not put down the cause of death. You put down the diagnosis that the patient had. And you can't put down sepsis as a cause of death or acute respiratory failure as a cause of death. You can't put down cardiac arrest as a cause of death. But you can put down severe ischemic cardiomyopathy. You can put down chronic kidney failure. But you can't put down, it has to be diagnosis based. If you can't do a death certificate, then we refer it to the medical examiner and then they would do it. So, I have a question to the panelists or any of the speakers. What is the statute of limitation there for a lawsuit? Can they just sue you anytime they want, or is there a specific limitation in when can you litigate somebody? Here it's 2 years at the time of discovery, so which means and I think the statute of limitation is 7 years. So within that 7 years, if it was discovered, it can be a lawsuit. But the statute of limitation otherwise is 2 years after discovery. So they have 2 years to sue you after the discovery. I don't know what the laws are in India, but if it's unlimited, that doesn't really protect anybody.
Yeah, Rakesh, in this law of discovery, while you were telling, I was listening to it very carefully. And this rule of discovery also prevails here.
Okay.
And suppose the time limit has passed, 2 to 3 years are there, then with some justified explanations, the court can condone the delay. And after a long time, the patient discovers that there was some negligence which is committed with that particular patient, then this discovery rule prevails. And in criminal cases, there is no limit. Various institutions like MCI, like our organizations like in law, limits are prescribed, but I think no limit is practically a person can file any case against an allegedly negligent.
2 years after discovery.
मतलब डल संडे बनाते हो हमारे यहाँ जाओ चाय पिलवाते हैं तुम्हें
Is Dr.
Dr. Mukul Tiwari is entertaining us.
शिवाजी कब आ रहा है
Dr. Mukul Tiwari, please mute yourself while talking.
अच्छा
Your phone call is on the air. Oh, he has removed his earphones also.
Dr.
Sirohi, please.
मैंने तुमसे एक बात करी थी प्लॉट की सेल करने की तो तुमने सलाह दी थी उससे फंस जाते हैं कई बार
Dr. Sirohi, are you there?
तो वो पार्टी है तो वो पार्टी अब उसने तैयार है कि एग्रीमेंट नहीं लाएगी
Dr. Sirohi can mute him.
उसके पास है अमाउंट तो उसका चेक बनवाएगी और बाकी कैश दे देगी ये तो ठीक है
I have a good question to the surgeons on the team.
अपने को स्टेप नंबर 1 क्या करना चाहिए वो सब तैयार हो गए हम तो तैयार हैं अब आप बताओ क्या करना है
Dr. Sirohi needs to unmute, I think. Yeah, it's all done.
Dr. Sirohi, please come in. Where is he?
Hello.
Dr. Sirohi को बोलिए ना म्यूट करें
क्या अपन तो सीधे एक ही दिन में चाह रहे हैं कि
Dr. Anurag Verma, can you hear me?
एक ही दिन में वो कर दो रजिस्ट्री कर दो 15 मिनट टाइम
I
देते हैं
want to ask one question in the meantime from Dr. Rupali. Madam, what is the differences between
Unless he is muted, you can't bring anyone else. It's very impossible because it's automatic.
ये शांत हो गया हाल में।
Dr. Rupali?
Yes, sir.
Yeah, I want to ask one question in particular from you. What is the difference between civil and criminal medical negligence as far as law of the land concerns?
Okay. Like just now, sir asked, Dr. Rakesh Mittal sir asked, what is the statute of limitations? So, sir, in civil court here, it is civil and consumer, it is here 3 years, and in criminal, there is no limitation. So the difference is in between a civil and a criminal, that the civil case, it is usually it is initiated either by the patient, and in the criminal cases they are initiated by the state, because when a patient or his relatives they lodge a complaint with the police station, the police they send all the documents to the medical authority of the medical authority board. The medical authority then decides whether the doctor is been negligent or not. If the doctor is negligent, they will send it to the police station. The police officer, the investigating police officer, he will file a charge sheet, and the case will go on in the court. So, but in civil cases, the patient initiates directly goes into the civil court. Usually these civil cases, they are done either for just for a small want, even a small want of care. Like I told you that the patient, he slipped in the hospital and then he filed a case in the civil court. But in criminal cases, there has to be a gross amount of negligence. Like if a mop is left inside the abdomen, or the patient has been operated on the opposite side, then in civil cases, it is usually done for only just for for remedial action, while the criminal cases, they are done to to punish the doctor. And there is a vicarious liability. It is not applicable in civil cases, in criminal cases, and it is applicable only in civil cases. And the fine is usually financial compensation, while in criminal cases, it is either they can be imprisonment or fine. These are the differences in civil and criminal cases.
And use a discussion, please. Join कर लीजिए. Okay.
Dr. Rupali Jain, can I come in?
Yes, sir. Yes, sir. Sure.
Excellent talk. Really, it was very, very informative. Just one or two things. You really pointed out few really good things which I was doing when I was in India. One is, asking people to sign a consent not on the day of surgery, which is a very good practice. Over here, I think very important time has come when you got a copy of consent, which you give to the patient on the day. Like elective, emergencies are different, when they come, you got a fracture. But if you're planning a surgery, you should consent on that day so that he can have an informed consent and he can absorb the consent. And when he comes for the day of surgery, you need to be with him again and reconfirm the consent by signing it again. So that means that puts you into a better situation legally, that you have told the patient there would be complication of, for example, infection, and he can't sue you because you had enough time to think about it and you were asked again on the day of surgery that these are the consents. So it's important, as you rightly said, informed consent, and it has to be. And other thing is, there's a limit to what you can put on the consent. The advice is any complication which is 1% or more has to be on the, like for example, infection, dislocation, or a revision surgery, there's 1% or more. And any complication which is significant but less than 1%, which means death, amputation, stroke, MI, they should be there. But I think you rightly said you have to consent them much early, not on the day, because the patient may not have absorbed the consent. So
yes. Especially
really
for
good
elective
talk.
surgeries.
Yeah, really, very good talk. Very nice to hear all about that.
Thank you, sir.
I have a quick question to the surgeons on the panel. Back in 1981, when we alcohol and then a final layer of betadine solution. And I do not recall that many infections, post-op infections. However, in the Western world, and Dr. Sethi mentioned about 14% infections and things like that. Why don't we practice that now? Back then, we didn't even have antibiotics. We had chloramphenicol, gentamicin, and
Tetracycline.
I think,
Tetracycline.
Tetracycline. I mean, there weren't even any antibiotics. I understand antibiotic resistance, the resistance part, but we did not have that many infections. I do not recall that. And then I was a first-year resident for a short period of time. Started my house job, never completed it because my mom and dad in Canada wanted me back there. But I do not recall in 4 or 5 years that many infections. Here in US, the first dressing hasn't changed and they're already growing MRSA. Obviously it came from the surgeon or the OR or whatever, or improper draping or something like that. Now here they use this betadine sheet and cut right through it. Why that practice? And I don't know if it's still practiced like that in India, where you prep the area with soap and water, basically, and then after that alcohol, and then the betadine. I could never figure that out.
I'll tell you. I mean, that 14% you're saying is it's one of the, pathways. He said it's patient who have got history of comorbidities, high BMI. Normally, the infection rate, anything more than 1 is going to be scrutinized. So the complication infection is about 1 to 2% realistically. More than that, you will be taken by heavy tasks. Like, for example, if I do a joint replacement and within 10 years, if it's replaced by any other surgeon. So if you operate, it goes into a central database. And this person moves from my area, goes to another area, and he has got to have a revision done. Can you hear? Yeah, can you hear me?
Yes.
Yeah. What will happen is, he will come to know this patient has been operated in such and such hospital at this time or on this date, and a revision surgery has happened. And if my results start going wrong, my clinical director is going to be intimated, there is something wrong with the doctor and they have to look into it. However, and that's how, it's a clinical governance as well, but helps into audit as well. But I would say the infection rate is not 14. 14, what my slide mentioned was in Parvez et al., where he's operated on patients who've got high comorbidities. But normally, I would say 1 to 2% is the acceptable. If my infection rate is 1%, I'm within my national guidelines, I'm allowed. But if my infection goes to 10%, I would be questioned. And on the consent, if you're going to have a patient with a revision surgery, we do tell them and document your complication is 10% as compared to primary joint, where if it's 10%, there's something not right with your surgical skill or the theater discipline. So yes, the infection rate has definitely going up for a reason of resistance. And I think we have to be very careful. And also we have started doing revision and re-revisions. Joint fails, okay, take the joint out, 6 weeks of antibiotic, go back again, because we have not started thinking about amputation. Nobody likes amputation. So re-revision and re-revisions are going up the ladder. And I think, and also antibiotic resistance will play. But generally, infection of 1 to 2% is what should be expected. And that's what we would say.
Dr. Govind Sethi.
Go ahead.
You talked about first generation cephalosporins.
Right, yeah.
Which is the one you are using?
No, you're right. You picked up with the right. I think you were really listening my talk pretty well. I can say that. Because I said our hospital using teicoplanin. There's a reason for that. You're allowed, it's not a cephalosporin, it's by and large, they recommend it, but not mandatory that you can't use anything else. The cephalosporin is because it's quite a broad spectrum antibiotic. Why we're using teicoplanin is because the half-life of teicoplanin is 7 days. So you only give 1 dose at the time of induction, 400 milligram. Let's not forget, I'm not treating infection, I'm giving prophylaxis. So if you get a teicoplanin and gentamicin, it covers all the bacteria. So the gentamicin 1 shot is given just with teicoplanin at the same time. But if I'm doing a joint arthroplasty, the cement which I use has already got a gentamicin impregnated into it. So I don't.
But what if you are not doing a joint replacement or anything else.
Then
If you're
I
doing
will
a ordinary surgery,
then I will give tycoplanin and gentamicin, whether
So
it's
that-
one screw
okay.
or it is 10 screws or a bigger plate or a small implant. Implant is implant because we are giving prophylaxis.
Supposing an orthopedic surgeon there is operating on a simple laceration
Yeah,
without any bony injury,
yeah. No
then what
antibiotic.
antibiotic?
No antibiotic, depending
No.
if the contamination, if there's an open wound, we don't give any antibiotic. I also do carpal tunnel, cubital tunnel release, small hand cases to fill up my list with a joint replacement. If I'm doing carpal tunnel, cubital tunnel, tendon sutures, no antibiotic.
That's
Dr.
great.
Sethi, Dr. Sethi,
Yeah,
is first generation cephalosporin available freely there at your place?
yeah, it is available, but
Because
we
in
are
India it is not freely available.
yeah, but the only thing is we just have to make sure how our microbiology department, we liaise with the microbiology and make
Okay.
sure we follow them as well. So it's not that the antibiotic is not available, but we are not somebody who will be sucked because we've got one another grade of antibiotic. I find in India, you're going one above the other, you see, to control the
Yeah.
infection. We are very much still basic. Will you be surprised for cellulitis? We are using flucloxacillin, a
You are
basic
using-
antibiotic. Flucloxacillin, just like a derivative of amoxicillin,
Yes.
500 milligram 4 times a day. That's all we give. Because we will go a stage above once we don't find or unless until we culture anything organism which is susceptible to it. So we don't go for the antibiotic culture is very much evident in India because I don't know why, but that's the reality. And the pharmacists, we are being driven by the pharmacist actually, the pharmacological company who are going one after the other. They are the people who are making money out of it. But I have a feeling because it's been the way we have been taught about, and I was doing the same. To be honest, I was doing the same till I've been here. I used to give antibiotic for 10 days, all my ankle fracture, 3 days of IV and 7 days of oral till the sutures are removed. I was always doing the same.
Dr. Tiwari mentioned availability of first generation. Are you saying that in India it's not available? Here we use ANSYS pre-op, pretty much every case. We don't use ticloporin that Dr. Sethi suggested, but we use ANSYS 1 gram before surgery. When Dr. Tiwari mentioned that is it available in UK, am I to understand that it's not used or available in India?
It is available in India. There is no problem of first generation cephalosporins. We have been
The,
using.
the cefazolin is not available in India, but other antibiotics are available in India. And cefazolin, I don't know why it is not available. That is the which came with the name of Reflin. That is not presently available. And the antibiotics, the regimens which Dr. Sethi has, we have been following only those regimens, and we have been using the cephalosporins, and we are into joint. We do around maybe around 30 to 40 joints in a month. And we also have only like knees usually have, because it's a superficial joint, the acceptable rate of infection is around 2%. And hip is a deep joint, and hence the acceptable infection rate is around 1%. And with the current practice, but the standards which Dr. Sethi has narrated, and with all those things, the infection has drastically gone down. And only in the comorbidities index, if they are more than 1 or 2, or if the ASA grade is high, then only the infection rate shows up. And in the revision situations where the infection rate is high, that each time you go inside the joint, there are increased chances of the infection. So with the standard guidelines and all those things, the infection rate has actually gone down, not increased actually. Thank you.
My one question to Dr. Mukul Tiwari is it true that no FIR can be lodged against your doctor?
Pardon?
Sir, is it true that no FIR can be lodged against a doctor
It is,
while on duty?
yeah, Jacob Matthews case versus the state of Punjab. this verdict came in that case by the Supreme Court. Although it has come, but it is still not binding on different state governments. And the verdict has given sort of the onus or the power to the states to implement in their own way. So it is not binding. And FIR may still be lodged, and in some cases you must be seeing that it is being lodged against doctors, especially when the case is res ipsa loquitur, where the mistakes or negligence speaks itself,
Yeah.
like right leg cut instead of the left leg. So this kind of obvious mistakes and another mistakes which are very obvious. So police is doing FIR. We cannot stop them everywhere with the help of this verdict.
Sir, if the police lodges an FIR against the guidelines, because in Jacob Matthews versus State of Punjab, the Supreme Court had said that the investigating officer will go to the scene and he will prepare a report to be given to the medical board. Okay,
Yes,
and
yes.
after the report comes, then the FIR can be lodged. But if a police officer can arrest a doctor in certain situations when there is he thinks it's necessary to arrest the doctor for collection of the evidences or furtherance of the investigations, or if he thinks that the doctor will not present himself before the court during the trial. So what I mean to say is that if the police officer, one of these type of cases has happened here nearby Kashipur, the police police have an authority to lodge an FIR without the report of the medical board in case of section 30A number 1. Police can arrest the doctor on other grounds. But as far as guidelines are concerned, if the police officer can arrest the doctor according to those guidelines, but he cannot lodge an FIR before the report of the medical board is there. So will this not amount to contempt of court if the medical report is not there and the doctor is arrested on this assumption of having done crime against section 304A?
Yes, it will.
This will amount to contempt of court.
Yes,
So,
yes.
so if the medical board's opinion is not there, that has not been attained, and the doctor is arrested, then the doctor can file, arrested under section 304A, then the doctor can file a writ petition for contempt of court against the police.
Yes.
Okay.
Yes, that can be done. That should be done.
Okay, sir. I want to ask one question from Dr. Satish Tiwari, sir. Sir, what are two important medico-legal issues which can lead to future litigation? These are the most important two issues in practice of neonatology.
Before that, I would like to interrupt Anuragji. I have an emergency and I have to leave. So
Yes, sir. Because
it was a pleasure interacting with all of you, such nice persons. Dr. Jaggi, Dr. Govind Sethi, Dr. Patil Jain, Dr. Rishi Bhatia, and Dr. Rakesh Mittal, and who else I'm missing?
Sir, actually, connection of Dr. Sirohi is not working. We are also very thankful to you for accepting our invitation and to join this webinar. And this topic, patient-doctor relationship, was up to a very large extent, it was improved. What I heard from you in Bhubaneswar. So I was thinking only that lecture, but this lecture of yours was very good.
My concepts have become more clear.
Yeah, and it has been modified according to the circumstances also.
Circumstances. Every time I change.
Yeah.
And I become wiser in last 5 years. So I have...
Dr. Mukul Tiwari, you are being modest. Yeah, it was a really good talk. Thank you very much.
Thank you, Dr.
Tiwari. Thank you, Dr. Tiwari. Thank you very much.
Pardon, sir?
Internet has improved now. Connected.
Thank you, Dr. Tiwari.
Very impressed with the hospitality of Dr. Anurag and Dr. Sirohi, sir. So I'll take leave.
Dr. Sirohi is the whole soul for these webinars.
Okay. Thanks to you, and I'll leave.
And And I'm sorry, having said that, I have to get ready, do my hospital rounds, and I have,
Yeah.
so if it's all right, I thank everybody. I thank Anurag, and I learned a lot from a lot of the presenters here. It was a very, very refreshing talk by everyone. And so I learned a lot about the Indian system, how you guys practice and whatnot, and it was very refreshing. So thank you so much. I just have to get ready and have a busy day. I'm on call too, so
No problem.
if it's okay.
Yeah, thank
Nice
you very
meeting
much, Rakesh, for joining
Thank you, Dr. Rakesh.
here
Thank you.
with us this morning. This is
Thank
early
you, sir.
morning
Thank you.
and you have taken pains to join us. Thank you very much for that. And one thing, I can trouble you in future also.
No problem. Just give me enough time.
Okay,
Thank
bye.
you. Thank you
Nice
very
seeing you. Nice, Dr. Mittal. Nice seeing you.
Okay, Dr. Mittal.
Thank you, Dr. Mittal.
Thank you. Thank you, everyone. Yeah.
Now, if Dr. Sirohi allows me, can I ask one question, supposedly to be the last one, as you were saying that there is constant of time at the moment. So, can I ask one question from Dr. Satish Tiwari, sir? Sir, what are
Yes.
the two most important issues in your neonatal medical legal practice which can lead to future litigations?
The one most important is as we discussed, ROP, the retinopathy of prematurity. And second issue, I think, is the birth asphyxia or perinatal asphyxia, which results into lifelong neurological damage or mental retardation. So these are the two important issues: the damage to the eye resulting into blindness, and second is damage to the brain resulting into mental retardation and lifelong handicap, especially in form of a spastic child. These are the two important issues.
And cerebral palsy with there are a lot of cerebral palsy cases in our practice. They must
Yes,
be.
spastic child means cerebral palsy. Yes, spastic child means cerebral palsy.
Yes.
We have one case from Uttarakhand only, which for 3 crores it is going.
Okay. Yes, Dr. Jaggi, you are asking.
3 crore case in Uttarakhand.
I was asking Dr. Satish Tiwari, do you have any case which has been settled in the court and doctor has been penalized for this blindness, neonatal blindness, premature births?
We have discussed one 1.8 crore and second was 67 lakh from Madhya Pradesh.
Okay.
And the third case which is going on in National Commission is again for 2.25 crores.
My God.
They know that
Alarming.
we can get
Very
this.
alarming.
Because
Yes,
they know.
Dr. Patil.
Yes,
Yes.
the third case on retinopathy is going on for 2.25 lakh. That is from Uttar Pradesh.
Dr. Bhatia, you are asking something?
Yes. I got comment from Dr. Satish Tiwari. To become a specialist, one should get registered post graduation in medical council of India. Is it compulsory to get registered?
Hello. Hello.
Dr. Bhatia, please repeat
Your
your
voice
question.
is not clear.
To become specialist, is it compulsory to get registered post graduation in Medical Council of India?
I cannot listen. Probably my internet connection is not proper. The question
Dr.
is not
Bhatia,
clear.
I think it is mandatory.
What was the question, sir? I could also not listen to it.
Is it mandatory to register your specialization in MCI to call you a specialist?
That
Yes,
varies
yes.
from state to, in most of the states, it is mandatory.
It is mandatory, Dr.
Yeah, yes, if the person who is practicing doctor, he has not registered in that state with that particular specialization, and he is doing practice of that. He cannot do practice of that without getting registered with the state medical council. I am pretty clear as far as Uttarakhand is concerned. Suppose a surgeon is doing surgeries and he is registered as a M.B.B.S, or a cardiologist is doing cardiac interventions, angioplasty and all that, and he is registered as M.D. medicine, then he will not be able to conduct this cardiac interventions as far as MSI is concerned.
Will he
Is
be
it
able
okay,
to?
Dr. Bhatia? Okay. So I think all the things are clear. We should come to the end of this meeting, and it is my pleasant responsibility to thank all of you for this.
Thank you, sir. So kind, sir.
Thank
It
you,
was
Dr. Himanshu, Dr. Rupali, Dr. Jaggi, Dr. Bhatia, Dr. Satish, Dr. Sethi, and Dr. Anurag Verma. Dr. Anurag Verma is helping me a lot in organizing these webinars.
good.
We are going to have a small meeting of IMA Uttarakhand, so that's why I am on constant. So good night to everybody.
Good
Thank
night,
you.
sir. Good night, Dr.
Yeah, good
Sirohi.
night, sir.
Thank
Good
you
night,
also,
everybody. Thank you.
Thank you, Dr. Sirohi, for all the efforts.
Okay, Dr.
Okay,
Tiwari.
bye.
Thank
Bye
you.
bye. Good
Bye,
night, Dr.
bye. Good
Tiwari.
night. Yeah. Good night, everybody. Yeah.
Sir, thanks a lot.
Okay,
Good
bye bye,
night,
Rupali.
and good night.
Okay, good night.
Bye, sir. Bye.